Hello everyone. I think we will start now. So we'll begin with our first presenter, Dr. Aina. Are you there?
Yes, I'm here.
Okay, sure. Are you ready?
Okay, can.
So we will start with you. One station two. Then we give you about 4 minutes to prepare. Once the time is up, we will start. Is it okay?
Okay.
All right. Let me just prepare. Okay, the time start. Now time's up, Dr. Aina. Are you ready?
Yes, Vin.
Okay, let's begin. This is the patient, Mr. Bob.
Hi, Mr. Bob. Okay. Just to make sure, are you 40 years old?
Yeah, I'm 40.
Okay, I'm Dr. Aina. I want to ask you regarding your why you came here, all that, because I want to know what is the cause. So, you was admitted here because you collapsed after playing badminton. So actually, may I know what happened before that, Mr. Bob?
Yeah, so doctor, what happened? I cannot recall the event exactly, but what I understand is that uh, after I played badminton around 3 o'clock, then I went to just sit down and rest while my friends are all resting as well. Then suddenly I fall unconscious. Then I cannot remember what happened. The next thing I remember was I woke up in the hospital and I feel a lot of pain over my chest.
Okay. So I know means that it happened during your rest, is it?
Yeah,
After
yeah.
playing
I mean,
badminton.
I have no issue when I was playing badminton. Then when I was resting after I prayed, then suddenly I have a backup.
Okay. I know is this the first episode?
Yeah, yeah. My first episode.
Okay. Before that, do you have any chest pain?
No,
Do you feel any heartbeat racing?
no,
Any dizziness?
no,
Okay. Before that, we feel shortness of breath.
no.
Any fever?
Fever. I don't really have fever, but actually 2 weeks ago I have a bit of flu. I got a cough and also runny nose, and that time I did have a bit of raised body temperature, but generally I took some medication for my GP and it gets better.
So no more fever after that, is it?
Yeah, no fever.
I know after you were having fever at that time, did the doctor gave you antibiotic?
No, the doctor told me just need to take Panadol and then just need to go back and rest.
So during during the collapse, so your friends saw it. Did they tell you that you're having any jerky movement during the event?
According to my friend, I straight away passed out like that and then was
Mm-hmm.
unable to respond. So they call me not respond. Then they feel my pulse. They told me this is after they told me after I woke up, they cannot feel my pulse. So they started chest compression on me, and during that time there's no movement over my arms or leg.
Okay. So there is no uprolling of the eyeballs.
They didn't tell me about that.
Okay. I'm sorry to ask you, when you collapse, did your friend notice that there is a stool or you passed urine at the time after the event?
No. I didn't pass urine or pass out any emotion.
Okay. So regarding the after you having your, the fever all that
Hmm.
before 2 weeks ago, then you mean there is no after that there is no such thing like no more fever, there's no more cough.
No, not really. Like, I mean, the cough has been there, but already improved.
Okay. Prior to that, you playing badminton. May I know where did you play?
Yeah, I play in the school hall.
Okay. So not under the sun, right?
No.
Okay. And before that, do you have any pain over your hand prior that?
Pain over my hand, no.
Mm. There's no problem when you raise your hand to play the badminton?
No.
Okay. Now, I know before that, are you taking any meal before that?
Taking what? Sorry?
Meal.
No, no,
So, do you feel no hunger prior that?
no,
Any sweating?
no.
Okay. Manu, do you have any heartbeat racing?
Not really.
Okay. Do you feel any headache prior that?
No,
Blurring of vision?
no,
Any you feel notice as facial flushing?
no.
May I know, do you have any history of any medical history before?
Medical issue. I'm quite healthy before this. I don't have any medical condition.
So you never had history of admission before, is it?
No,
Okay. No history of accident,
no,
motor vehicle accident. Okay. Do you have done any surgery before?
no,
Okay. May I know, do you take any current medication?
no.
So after the Panadol, you didn't take any other medication, right?
Yeah. Only Panadol.
Okay. I'm sorry to ask you, do you take any illicit drugs?
No.
Okay. I want to ask regarding your family.
Mm.
Have you encountered, in case in your family members having similar episode before?
Similar episode as in like collapse, no. But my father actually passed away even before I was born. He passed away at the age of 48 years old due to some heart problem.
Okay. And your mother, she is well, is it?
Yeah, she's well.
How about your siblings?
My siblings all, I mean, I have two sisters. Both of them are okay at the moment. They don't have any heart problem. So doctor, that time, because of my father, suddenly passed away like that, we are told to go for some screening of the heart. So I remember when I was younger, I did a scan over my it's like an ultrasound scan over my heart, and then they told me, oh, my heart is normal. No, there's no issue.
Okay. Do you have any follow-up again with the doctor regarding
He
what's
say
going on?
they say no need to follow up. I've seen them about two times, one each year. Then they say it's normal, can be discharged.
Okay. Do you have any allergy?
No,
Okay. I'm sorry to ask you, are you a smoker?
no, I don't smoke.
Okay. You didn't take, did you take any alcohol?
No.
Just in case, when you follow up, did they inform you your blood pressure all normal, is it?
Yeah. I mean, that time I was about 20 to 22 years old. I was normal.
Okay. Do you have any limb swelling?
No,
Any rash noted over your body?
no,
Any hand shakiness?
no.
During the event, did they inform you that your face become bluish?
Fish become what? Sorry?
Bluish.
Bullish.
Bluish.
I was not told. Not very sure.
Okay. Okay. May I know what is your current occupation?
Yeah, I work as a supervisor in the one of the company. So my I think I have no problem. I also quite do some light exercise as well when I was not at work. I don't find anything unusual. This is something very scary for me. It's like the first time in my life.
Okay. Also to ask you, are you married?
Yeah. I'm married. I have two children now.
Okay. May I know what age of your children?
Actually very young. One is only 1 year old, and another one is 3 years old.
May I know before the event, you said that you're having no dizziness, any dizziness?
No, no. You have asked me twice.
Oh, okay, sorry. Um, okay, may I know your concern, Mr. Bob?
Yeah. So doctor, what I'm having actually?
I suspect you may have uh, heart, heart problem. Okay, it may similar with your father. Okay, because your father also you said passed away 48 years old, which is quite young also.
Mm-hmm.
Okay, even you already done the screening, but it may one of the precipitate. You have history of runny nose and also cough before. Okay, and I'm not sure other medication that you take previously at the private doctor, but it may precipitate your heart. The tracing of the heart that's causing a sudden collapse currently.
Mm-hmm. So what is this condition?
Okay, I suspect you may have actually probably having what we call like long QT syndrome. Okay, that is causing when you take there's a certain precipitant that when you take it that may cause your heartbeat having irregular. Okay,
Okay.
so for that, we have to investigate you. Okay, we check your heart tracing again. Okay, do some scan and do some scan to you to make sure you are not having this.
Oh, okay. Doctor, can I exercise then?
Okay, so for now, I suggest you not have a rest first. Okay, until we find out what is the cause.
Okay. Doctor, I haven't completed my family yet. Is there any issue if I have any intimate relationship with my wife?
Um, actually, your condition, it can usually it can precipitate by having, um, it can also occur, okay, if you're having a relationship with your wife. So I just suggest for
2 minutes
now,
left.
you have a rest first, okay, until we investigate the condition of your collapse.
Okay. Is there any medication for my condition?
Actually, for you, I will refer you to the heart specialist to see first. Okay, they probably might see your heart tracing first, and if really what I suspect to you is really the cause, you might have to wear machine to regulate your heart tracing back.
Oh, machine. Does it mean I need surgery?
Mm, for now, I'm not so sure. I have to refer you to the heart specialist first.
Okay. But doctor, you said that I cannot exercise for now, but this I black out that time. I'm not exercising. I'm just resting. Is it really related to exercise?
Mm, it can be because it occurs after your exercise also. Yeah.
Oh, okay. All right, doctor.
Is there any other concern?
No, no, doctor. You still got 30 seconds, so probably at this time, if you encounter this in real exam, you can do a quick summary. Hmm? Dr. Aina, you have anything to say?
Mm,
Then my 5 seconds remaining.
fine now.
Okay, all right. So, Dr. Aina, you have 1 minute for reflection.
Okay.
Okay, 1 minute is up. Dr. Anna, can you tell me what are your differential diagnosis and your provisional diagnosis in this patient?
I suspect this patient might have long QT syndrome. My differential diagnosis is actually hypertrophic obstructive cardiomyopathy.
Okay,
And then third one is Brugada syndrome.
okay. Is there any differential diagnosis?
Patient might have vasovagal syncope.
Okay. But how do you rationalize the diagnosis of vasovagal in his case?
As patient being collapsed after the playing badminton.
But it's not during the episode of doing any activity, right?
Yeah.
So probably it's less likely. Any other differential?
I'm not sure if she has subclavian syndrome, but she said no pain while playing badminton. So
What syndrome?
subclavian syndrome.
Oh, okay. What is your clue towards long QT syndrome or Bugada or the Holcomb in this case?
Because of the father had passed away at 40 years old, and they have to do the screening of the heart.
Okay. All right. How will you investigate this patient?
I would like to do ECG, electrocardiogram, echocardiogram.
ECG, what do you want to look for? Because you're telling me all these differential diagnosis, and how do you confirm the finding?
Okay, I want to see any prolonged QT.
Mm-hmm.
Okay, also any heart block.
Mm-hmm.
Okay, and then probably
Okay. How about echo? You mentioned echo just now. Is there anything you want to find in particular?
echo actually for the Mock and Holcomb. So I want to see is MR, I mean material gravitation, systolic anterior motion, and also anterior, I'm not sure the hypertrophy, septal hypertrophy.
Okay. All right. So any investigation? Any other investigation?
I would like to do halter.
Mm-hmm.
Okay, and then still I want to throw out like electrolyte
Okay.
that may
Good.
cause precipitate the long QT, prolonged QT.
Mm-hmm.
Okay, serum and then still creatine kinase. I still want to rule out any acute coronary syndrome.
Okay, but you mean troponin or
Oh, yeah, I
creatinine
mean,
kinase?
yeah,
Yeah. Okay.
troponin.
Any other investigation?
Mm, chest X-ray to look for any cardiomegaly.
Okay. How will you manage this patient?
Usually for the long QT, if there is electrolyte imbalance, I have to correct all the electrolytes. Okay, and then if it is actually, if it's a congenital long QT, so I have to refer to the cardiologist. Okay, and patient might be, put on ICD.
Okay. So before going to the electrical device insertion, just want to ask, what long QT syndrome? There is actually 3 common subtype, but which subtype this patient belongs to?
Sorry, I'm not sure regarding that.
So that it's not precipitated by exercise, emotional stress, swimming, or even sleeping, right? So does that make your diagnosis likely in this scenario?
Yeah, actually, not prescriptive.
So what would be your other likely diagnosis, provisional diagnosis in her case?
How come?
Okay, time's up. Okay. So, yep, we will discuss about this case. Okay. So, Diana, how do you find about this scenario?
So actually, I think because there's no precipitator, right? So
But
unless
why do you
the
commit this as a long
two,
QT when you cannot find any obvious precipitating factor?
just because of the family history only.
I mean, family history of certain cardiac event, yes, you put the congenital high in the list, and the patient also offered to tell you that there is a previous echo done on him for screening was told to be normal. So yes, you're thinking more to electrical arrhythmia kind of thing with a structurally normal heart, presumably normal heart, not sure. Then you are hitting hard on those differential, but you actually cannot differentiate based on those differential, right? So there is no obvious precipitating factor other than patient have a recent flu. Does that give you any clue on this?
Mm, I'm not sure.
So this is not this is actually not an easy scenario lah, because actually collapse can be divided into either seizure or syncope, right? And you are quite sure that this is seizure because the history outside the information given did a chest compression, give shockable rhythm, and then was actually admitted to ward for observation. So definitely you are dealing with cardiac syncope, and this is the first episode. Patient is a young, 40 years old, and you are dealing with presumed structurally normal heart with possible some form of arrhythmia, congenital related, because with a positive family history of father having certain cardiac event, and he's also there is some preceding URTI symptom. So with this condition, because you cannot find any activity that can trigger this event, so it makes a lot of things less likely. For example, long QT, congenital long QT can be, but usually they are precipitated by some exertion. But this patient, yes, after playing badminton, he rests. But this episode actually occurred at rest instead of during playing badminton. It means that this syncope is not really related to exertion per se, because with exertion, then by right, he should have collapsed earlier while he was playing badminton, right? So this is something that the history is still very important, because from this information you know that probably the precipitating factor is not just exertion, and therefore it makes your long QT. You also asked about sleeping, but you didn't ask about emotion, whether the patient is how is the patient emotion recently, is it stressful, things like that, which may precipitate the arrhythmia. Let's say that is lah, huh? So there's a few things that can go through lah. But generally this is not long QT because there's no supporting evidence other than family history lah. No? Do you know about the criteria, diagnostic criteria for long QT syndrome?
Don't know.
Don't know. Let's see. Did I have? Do you? Yeah. You have my notes, right?
Yeah.
Yeah, you can turn to page 88. Yeah, for the rest of you, you can search this what we call as Schwartz criteria or Schwartz score. So in order for patient to fulfill long QT, we don't need to know the criteria in detail, but you just need to know that you can see that the positive family history. Even if you go to the but I didn't mention about the score for each, but actually positive family history is only 0.5 score, which is quite low. So, and you can see that the history of syncope, if it's a stress-induced syncope, then it's actually a score of actually high score, about 1 or 2. And then whether patient got any deafness or not, you are suspecting that you should ask whether patient have any hearing difficulty. And the main part of the score is actually the ECG criteria, which score about 3. Let's say patient got family history and the ECG suggests it, then definitely yes. But let's say you don't have the ECG, and you at the history you can also actually ask about the patient. Patient did the previous screening, right? Did the patient told by the doctor that the electrical activity of the heart got any issue or not? You didn't ask about that. So if you ask about that, they can give you some clue. Let's say they told you the doctor say normal only, no issue. Then most likely it makes the diagnosis even less likely, right, for this kind of scenario. And the patient did not take any obvious drug that can precipitate QTC, that can prolong the QT. For example, the anti-malaria drugs or the antihistamine. Because I specifically mentioned that the patient only taking the Panadol, and there's also no antibiotic used like all the macrolides. So again, it makes the long QT less likely. So this is not an easy scenario that you really need to think through which is more likely. You mentioned Hokum. Yes, Hokum is a possibility, but Hokum usually they will have some hypertrophic, whether it's apical, septal. Usually they will have some LVOT. So those are the structural abnormality that predispose to syncope. But this patient told you the echo previous scan was normal. So again, this makes Hokum also less likely, but cannot exclude because we don't know what happened. Because Hokum usually in a younger age group, they may not have any symptom. Subsequently, when they progress, they may have symptoms. So yes, we cannot exclude Hokum, but Hokum is something that definitely I'm not going to put at the first provisional diagnosis. The next you mentioned about Brugada, right? The third diagnosis you mentioned about Brugada. So can this be Brugada?
I'm not sure though.
I mean, definitely you put under your differential diagnosis is possible lah, huh? So yeah, and Brugada, something special with this Brugada is it is usually not exertional, meaning to say it happened at rest or doing any activities. It is not really related to stress or any activity. But in a certain scenario, Brugada can occur. I mean, patient with Brugada syndrome can present with sudden collapse or syncope or palpitation. That is when they are sick, when they are unwell, and or they are taking some drugs like sodium channel blocker, very particularly, or even they are taking some illicit drug. Yes, you ask about illicit drug, you ask about all other over-the-counter or patient-owned medication in which all is negative. But because patient give you the history of 1 to 2 weeks ago developed a flu, and this should trigger you that, and some more this sudden collapse is actually not really related to activity. When patient is resting, and then because usually after playing badminton, after the exercise, the body temperature can be high, and if patient is still not well at that time, definitely patient have higher risk to develop collapse if patient have Brugada syndrome. So this patient is actually a Brugada lah, huh? It's actually a Brugada syndrome. So yeah, I can see just to go through, you have exclude seizure, yes, but your question is still a bit jumpy. When you ask about collapse, right, you should ask about pre-event, during the event, and post-event. You shouldn't like jump. I mean, after you ask us, then suddenly your face turn blue. So you should organize yourself to ask about the event. After you ask about everything, then you don't have to go back. So the reason why you have quite a number of times, because the HOPI part, I feel there's something that you still need to ask. For example, how to decide vasovagal syncope. So you should actually ask, yes, first you should establish whether this is the first episode. Yes, you mentioned, have it occurred to you any has this thing happened before? No. So this is the first episode, and then you need to know what is the trigger, right? So you need to ask particularly. So what were the patient what was the patient doing during that time? So patient told you that he was just sitting. So probably you should ask a bit longer, and you are just do you fainted right after you sitting, after you finish playing badminton, or sometime later? So it's also very important when you ask that to know that whether this is really exercise related or not. Okay, and after that, during the event, has patient any experience any preceding aura? For example, has he have any abnormal taste or abnormal smell, any blurring of vision during that point of time, any racing of heartbeat, chest pain? You ask about that, yes. And then post event, you ask only about I think you ask only about urinary and bowel incontinence, and you top up with the facial color changes after that. But generally, you should ask how long he recovered. But I mean, it's difficult. He may not know, but this is a question that we should ask. If he don't know, he don't know. If he know, he say that, oh, according to doctor, I actually woke up after they have restored my heart rate, and I can he recall the event or cannot recall the event? Usually seizure will have some post-ictal phase, whether there is a weakness of the limbs or because of some drowsiness, so may not able to recall a lot of things like amnesia like that. But this patient able to tell the event before he fainted, and he actually recovered quite fast after the heart rate is restored. So you should also ask about trauma. I realized that you ask about surgical, any surgery done, things like that, but you didn't ask about trauma, because in any high impact activities, for example, we don't know what happened during the badminton session also. Like suddenly, maybe it's rare for badminton to happen, but it can happen in, for example, a high velocity sport like rugby, or even for softball or baseball. Those kind of ball that accidentally hit the chest, this can actually trigger a sudden collapse, something what we call as commercial codis. So badminton is quite rare lah. We are being smacked also, we don't feel much issue, but we should still ask about this, any trauma. Who knows, the friend actually accidentally hit his chest with the racket, we never know, right? So we should ask about the trauma as well. Okay, so yes, you got the family history of father actually passed away young age due to heart problem, and generally there is no obvious cardiovascular risk based on your assessment of the history. So this kind of very bland history, like not exertional, should makes you put Brugada syndrome to be higher up in the list, because Brugada syndrome is something that can be very asymptomatic. Just some ECG changes, let's say they did ECG, and sometimes the ECG changes may not be obvious unless you provoke, you challenge it. So that's why it's not easy. It's not an easy diagnosis to make. Most of us make the diagnosis because we see the Brugada pattern on the ECG, which is a curved ST elevation on V1 to V2, sometimes V3. But generally, some like Brugada type 2, we don't see the ECG pattern. A lot of times, this will be missed because they generally don't have any symptom. And even if they came in like syncope or even cardiac arrest, they usually is not exertional from the history. So again, you need to find out what is the precipitating factor. So for him, it's a URTI lah, and also probably because of the high body temperature after he had the badminton. And then another thing is, when you're dealing with the differential diagnosis, you can actually give a lot of differential diagnosis in this scenario. If you know this is a cardiac syncope or sudden cardiac arrest. So you can see that this is can be long QT, like I say, yes. Can be also repolarization syndrome like Wolff-Parkinson-White, can be Hocken. Can also be catecholamine polymorphic VT, CPVT we call it, which usually present with bidirectional VT. But usually CPVT tends to occur in the younger age group and usually will precipitate by exercise as well as emotional stress. Usually the first onset is during the childhood. So you should really need to ask about that. And yes, at examination you want to order cardiac MRI, particularly TROP eye. Nowadays no one do CK already lah. ESC recommend high sensitivity TROP eye just to diagnose. And FBC, serial ECG is also important instead of just one ECG. Echo is basically to go out for any structural abnormalities. And this patient, if you are suspecting it's a rhythm disorder like long QT or even Wolff-Parkinson-White or polymorphic catecholamine VT or even Brugada, then you should actually refer for electrophysiological study and may consider provocation test. In Brugada, there's two types of provocation tests. One is called, both are actually using the sodium channel blocker. We know that flecainide can be used, which is a Vogan-Williams class 1C. Another one is more commonly used, is actually ashmalin. But I think in Malaysia, we don't really have ashmalin. Only certain center. Generally, we can use flecainide. So what we do when we provoke the patient with sodium channel blocker, because Brugada is a defect in the sodium channel, congenital defect in the sodium channel mutation. So that's why if you give sodium channel blocker, you will precipitate the symptom. Patient may develop VT in the cath lab, so which require immediate cardioversion. So this is also something that need to confirm the diagnosis. Sometimes it's difficult. So again, other than echo, you should also measure about cardiac MRI in this scenario. Because cardiac MRI, echo, we know that the sensitivity may not be too great unless it's so obvious, the septal hypertrophy, apical hypertrophy, or mitral valve prolapse. Generally, if it's like not much of issue, you may need to proceed with cardiac MRI. Because certain diagnoses may not be obvious unless we see at the valve and the coronary sinus, which is very, very small. So that's why it's also important to suggest for cardiac MRI. Another one you should mention is, even if you suspect it's a long QT, you should mention about genetic testing. Long QT also you should mention about genetic testing. Brugada lagi need to mention about genetic testing. We know that the genotype that is most likely associated with Bugada is actually the SCN5A mutation. If you know, if you don't know, it's okay. It's not very important. Then the management, yes, patient education, counseling, MDT, cardiologist. Generally, for Bugada, if you diagnose someone with a Bugada, and the patient just have a sudden cardiac arrest, not that yet. I mean, arrest is a out of hospital arrest. This is considered secondary prevention, and the management is no longer medication. Must ICD, must use ICD. And unless the patient have no symptom, then you may, patient did not present with sudden cardiac collapse, patient presented with syncope or for example palpitation, then yes, there is maybe a role of giving medication like quinidine or epicardial ablation. Or sometimes if patient refuse ICD insertion, the only way is to do is the ablation therapy is better. And we also need to know about this Bugada because not every drugs can be given in this patient. Certain drugs like alcohol, like sodium channel blocker, like lithium, like anti-epileptic, carbamazepine, phenytoin, SSRI, antihistamine, and high dose caffeine. So in this scenario, you should also ask about coffee intake, because we know that suddenly, often all those arrhythmia may be actually induced by coffee as well. So it's important for any scenario of syncope, should ask about caffeine intake. You ask about illicit drug as well. So all those things should be avoided. And if patient have any fever, should treat the fever promptly. In this scenario, you should measure the blood pressure, measure the temperature to make sure that patient is not ill. And this is for the acute management. Subsequently is the genetic family screening. So we generally screen Brugada patient with ECG and also echo normal, then we just follow up with ECG. Usually need to screen very young onset. Usually I think the guideline changes. It started early, actually about 15 up to 20 years old. And if the follow up is normal, then yes, it's safe to discharge. But generally we don't discharge the patient early. We only monitor, screen with ECG. And then lifestyle modification. This is something that is not really exertional. So the most important thing you need to counsel them is whether heavy activities or moderate activities is debatable, but you can say that you still can do a light exercise, not to say you cannot, but have to make sure that your condition is optimized first. And yes, so if you ask me about, you mentioned to insert machine or this device, right? So if you manage to have time, then I actually can ask you whether I can just take medication. I don't want to insert that, but because you don't want to commit that time, you say may require, so I don't want to mention about that. Yes, actually for any heart problem, right? Even for MI, the guidelines say that when is the earliest time you can, patient can have sex with the wife or the husband. Actually, is the guideline never have any obvious duration or guideline, but the guideline says that the patient can have any intimate relationship after the patient become better in terms of the symptom. If patient no longer have any symptoms of failure, any cardiac symptom, then yes, they may have the intimate relationship. It's not contraindicated, and there's no exact duration on that. Okay, so
means that after he was put on ICD, then
yep.
he can
For ICD,
exercise.
there's no issue. Yeah, there's no issue. Okay, so do you have any question before we proceed? I got a few more other slide to mention about the differential diagnosis in this case, as well as the Bugada.
So far, no.
So far, no, right? Okay, so generally in this case, probably you will lose mark in the differential diagnosis and the clinical judgment. You won't be getting less than half of the mark, maybe about half of the mark, maybe half of the mark or slightly more. So you can see that getting a correct differential diagnosis, because actually you still be able to save yourself in the sense that your differential diagnosis, the Bugada, is part of your under your working diagnosis, so it's still safe in this sense. But you may not able to get 2 marks, you can get only 1 marks. And clinical judgment, generally some examiner may give you 1 mark, because if it's like almost the same thing like ECG, echo, sometimes they may give you, but some strict examiner may not give you. And I think generally you will still able to pass this station, but just borderline pass with this station. You need to get a very good idea of the situation of the diagnosis and to exclude it from the differential. Okay. So when we encounter any scenario of arrest, cardiac arrest or sudden cardiac death, we always need to divide the differential diagnosis to be either structurally normal heart or abnormal heart. Because structurally abnormal heart and normal heart, the differential diagnosis is different, it's very different. When you talk about structurally normal heart, you're talking about arrhythmia, cardiac arrhythmia. It's usually arrhythmia or any repolarization syndrome. So Bugada, out of the structurally normal heart that causes cardiac arrest, Bugada is the commonest. Okay? And out of the structurally abnormal heart that cause the cardiac arrest, can be two. First is the Hockham. Second is actually coronary artery disease. Usually those long-standing coronary artery disease, which is more than 35, then they are higher risk to develop because they have already got some form of ischemia, myocardial ischemia. That's why they are like those scar VT and VF. So still commonest for structurally abnormal heart. Younger patient is Hockham, older patient is coronary artery disease. Okay, but for structurally normal heart, the commonest is still being, or for younger patient, the commonest, younger or middle age, commonest is actually Brugada, followed by long QT. CPVT, yes, you can put in your differential diagnosis, not wrong. And commercial coding is something very acute. So, like for example, baseball player, those two things, tell you, then you really need to make sure there's no preceding trauma. Okay, and may actually occur immediately after the trauma. And other channelopathies are very rare, but generally you need to know the channelopathy is the common one is Brugada and QT. Bear in mind that short QT syndrome can also predispose to cardiac arrest as well, not only long QT, which is part of the channelopathy. Electrolyte anomaly, usually there is secondary cause. And Wolff-Parkinson-White early repolarization syndrome, yes, usually also we need to put in our differential diagnosis, especially when they present with AF. So Wolff-Parkinson-White usually it does not progress to cardiac arrest. But if Wolff-Parkinson, that if this early repolarization syndrome has concomitant AF, then this is something that we need to intervene early. Okay, so it's structurally abnormal heart. Yes, someone mentioned the ARVC is also part of the differential analysis, but generally ARVC, they tend to have symptoms very early. This is a congenital enlargement of the right ventricle, which actually causes reduce in blood flow in the coronary sinus, especially the right coronary cuffs. So that's why this kind of patient usually present quite early in the young onset. And dilated cardiomyopathy, you need to screen for thyroid symptom in this patient as well, because actually this scenario you have plenty of time. You need to make sure that you're not dealing with any other problem. And myocarditis, I will expect you to mention that in one of the differential diagnosis, although I didn't mention that in the calibration. But because patient have flu-like symptom, some virus infection. Recently in my ward got one patient that came in influenza A positive and just passed away. So actually the patient have myocarditis because we did the angio. It was a minocar in which there is totally no coronary artery stenosis at all. It's a perfectly not healthy coronary vessel, but patient still succumb because of the myocarditis. So you can see that myocarditis is something that we also can miss out quite easily. So we need to ask about any preceding fever and any flu-like symptom. Myocarditis is also a possibility in this scenario. Okay, and the rest of it is not very common. Congenital abnormalities in coronary artery like Al-Kappa is one of the commonest cause of MI in pediatric age group, but generally for adult, very rare. We don't see that because even if they have been diagnosed, the operation will be done. And the rest of it, generally this is how we classify. Valvular heart, we are talking about mitral valve prolapse, aortic stenosis. Those kind of patient tends to have a syncope. Okay, so just go a bit on the Brugada syndrome. So Brugada syndrome, you can see that elevation provocation test is a sodium channel blocker, whether you want to use ashmalin or you want to use flecainide. ECG, very importantly, you can see that ECG sometimes may not have a typical Brugada wave, and that's the reason why 12-lead ECG may not be sensitive. Nowadays, we advocate the use of high-lead ECG placement at V1 and V2. That means we put the lead, instead of at the second intercostal phase, we put at the first intercostal space for both V1 and V2. And if this is a Brugada, then we should be able to see a curved ST elevation followed by a T inversion pattern, classic Brugada pattern. So that's why it's called high lead ECG placement, only for V1 and V2. So you should really mention about ECG if you're suspecting Brugada. If the ECG is not suggestive, probably you should do a high lead ECG. Okay, And if it's highly also not suggested, if you want to confirm it further, you may want to proceed with provocation study in a patient we have a strong family history. So the risk stratification is actually whether patient presented with syncope, arrest, or this is actually a type 1 ECG, which is classic Brugada pattern. And the rest of it, you can see that the management, if patient have Brugada sign on the ECG, but no family history of certain cardiac event, no syncope episode, everything is negative, there's no risk factor, then this is not called Brugada syndrome. Brugada syndrome must have a classic ECG pattern together with additional clinical criteria, which I'm going to mention next. Okay, so pharmacologically, you can use quinidine, but generally they are not much, actually not very helpful. All the dysarrhythmia, you give medication is not helpful, especially those present with certain cardiac event. The management is still secondary prevention with ICD, or another case is ablative therapy. Aina, do you know of any diagnostic criteria for Brugada syndrome? Or anyone know about any diagnostic criteria of Brugada syndrome? Not sure, right?
Not sure.
Yeah. So recently, not many years ago, quite recent, China actually came out with what we call a Shanghai diagnostic criteria. So there's this diagnostic criteria called Shanghai criteria, in which you can see that if the ECG is suspect of type 1 Brugada, which is classic curve ST elevation, is 3.5, and 3.5 is already definite Brugada already. So if it's a fever induced, then can be lower score, or if the ECG that only shows Brugada sign on provocative drug, then it's actually a score of 2. And you can see that clinical history, unexplained cardiac arrest already considered 3. Let's say patient got this and this, already confirmed Brugada. Okay, and nocturnal, usually difficult, and suspected syncope due to cardiac syncope, then you can put 2. Sometimes the syncope is unknown, you can put 1. And then if patient suddenly develop AF for some reason, and if first degree hilarity with confirmed Brugada is 2, is suspect for Brugada or unexplained is 0.5. And you can also see that, let's say a patient did some genetic testing, SCM5A positive, alone, without anything, 0.5 is not really pointed towards Brugada. Okay, so this is actually the criteria to diagnose Brugada syndrome. But generally, we don't need to know very detailed. We just need to know that there's this criteria to diagnose and what are the components of it. Patient might have some family history. Patient might have some clinical history of syncope. And patient will have an ECG that is suggestive. If not suggestive also, you have to provoke it in order to get this criteria. So, a bit on the management, you can see that for Brugada syndrome, you should avoid those Brugada drugs which may trigger the Brugada arrhythmia. So basically, you have to, once confirmed, you have to follow up with the cardiologist and then screen the family members and then report if let's say got any episode. Quinidine is usually, like I said, quinidine is not very useful generally, and unless patient already like on ICD and then still develop some syncope, then yes, you can start quinidine on top of ICD. Or those patients that really refuse surgery, then may consider that. And medical management, because actually quinidine only works for atrial arrhythmia, it doesn't work much on the ventricular part. So if it's developed ventricular, then it's still high risk of death. And then other than that, ICD is still the first choice, and it's also recommended as a primary prevention for those confirmed Brugada. So ablative therapy can be also used if let's say not really suitable for ICD. So it's ICD ablative followed by quinidine in terms of the choice of preference. Okay, so generally that's it for the first station. Anyone have any question? If not, we will proceed with the second candidate. Anna, you're clear, right?
Yeah.
Okay, alright. That's all. So let's proceed with Dr. Abu. Are you ready, Dr. Abu?
Yes, I am here. Can you hear me?
Yeah, I can hear you very clear.
Okay.
Okay, so I will give you what are we doing? Let me check. So basically I will give you station 4, station 4, okay?
Okay.
So you will be doing a station 4. I'll give you 4 minutes for preparation, and 4 minutes is up. We will proceed. Okay?
Okay.
Alright, the time start now. Dr. Abu,
Yes.
okay, let's start. So this is Madam Aisha.
Yes. Hello, Miss Madam Aisha. Are you 40 years old, Miss Madam Aisha?
Yeah.
I'm Dr. Abu, one of the registrar in this neurology unit. I am here to discuss with you about your current health condition. Is it okay with you?
Yes, doctor.
Yeah. Before we start, can you tell me how much do you know about your current health condition?
Yeah, doctor. I was told that my blood pressure was very high and that actually causes me to have a stroke. And they told me actually this kind of stroke is a bleeding stroke in which my part of my brain have some bleeding because of the high blood pressure. And otherwise, the doctor told me can observe, no need to do operation, and because it doesn't bleed too much. And actually, I still can move my left arms and leg. I was told the bleeding area is over my right brain. And however, I think yesterday one of your colleague actually have done some procedure to collect the fluid at the back of my spine. Yeah, I want to know what happened actually.
Yeah, Madam Aisha, thank you so much for telling me all those issues. So, actually, I am sorry to tell you actually regarding this tapping yesterday we did was a mistake from us actually.
Huh? What is this supposed to mean, doctor?
Actually, it was planned for your neighboring partner in the hospital, neighboring patient. But unfortunately, one of our medical officer mistakenly has done this on you. Are you
Oh
after
no!
that? Yeah, I'm so sorry to tell you that.
How can this happen, doctor? This is a hospital. How can this thing happen?
I'm so sorry to tell that. Actually, I was not there, but it somehow happened.
Doctor, I not happy lah. I want to complain.
Yeah, actually, if you want to complain, surely I will help you. We have the patient assistant and liaison service. So I will give you all the brochures and leaflet after this conversation is over. So you can know and actually you can complain as well.
Yeah, but other than complain, what is going to happen to me then? This procedure will potentially cause a lot of issue then. I'm having bleeding in my brain.
Yeah, actually, fortunately, this your bleeding is very small. So our actually consultant has decided not to do anything. Hopefully, you will recover with time.
Yes, but
How do
now
you
that
feel
you're
now, actually?
mm-hmm.
How do you feel about your hand? Is it okay? You can move better?
I mean it's still the same. It's still the same. But I worried lah, doctor. Your colleague put in the needle to tap on it and then collect my brain fluid, and then will this cause worsening of my this bleeding?
Actually, uh, can I ask you one more question? When this, the tapping was done, that means taking fluid from your spine, when it was done?
Yeah, like I told you, it was yesterday evening.
Yesterday evening. So it
Hmm.
is now 3 p.m. So I think it is.
No. It's not 3 p.m. Your colleague is rushing. That time was about 5 p.m. And then it's like very chaotic. Your colleague want to go back home and then do this procedure. And then I don't know what happens. So they need to go through this procedure. So he asked me to sign the consent. I straight away signed. Then he did it. And then this is what happened. But how can this happen, doctor?
I'm so sorry, actually. Maybe it was, I guess, that the somehow our medical officer mistakenly choose your neighboring patient. We need to actually do the root cause analysis. We need to improve our patient identification system. Maybe somewhere some mistake has been done. We will go through about it for sure. So we will put this issue in our root cause analysis team, and I'm going to take this issue to our consultant and all of our colleagues, and we will discuss it in our all those setup. So before we do that, I just need to know that it was yesterday 5 p.m. Now it is actually 3 p.m. right today. So do you feel anything, dizziness, drowsiness, or any more problem in your hand, legs, anywhere?
No. I'm okay at the moment, I think, but I'm worried lah. Later on, things can happen. And I want to know who is your colleague lah. Can I know the name of your colleague? I want to complain.
I'm so sorry. Actually, we work as a team. So I'm so sorry that actually, that actually it's a mistake from all of us. I'm so sorry to tell you that. I'm so
I don't
sorry.
want your sorry. I want
I,
the explanation and solution, doctor.
Yeah, let us settle your health issue first. So it seems that actually it happened already around 24 hours almost. So nothing happened. So most likely, actually, the complication like bleeding will be very less likely. So, and then I think our colleague did it in an aseptic way. So when this kind of spinal tapping is done, actually of course, we do all the procedure.
Sorry, doctor. What is aseptic?
Sorry, I'm so sorry. To look after all the precautions so that you don't get any infection from when this procedure is done.
Okay.
So actually, there is this kind of procedure. Any procedure we do, there is some chance that you can get some new bug. There is some chance that actually there's some bleeding. But in your case, I think it should be a bit unlikely because you are. Do you feel any headache now?
No, I don't feel headache.
Yeah, that's a bit relieving to hear from you. I'm so sorry. I apologize from our whole medical team again and again. Actually, this has no excuse. It should never happen. So, as I say, what I'm going to do is actually I will inform this to my consultant, and also we have the root cause analysis team, including the ward in charge and doctors. So we will actually put this issue into that, and in our monthly we have some morbidity the discussion about the patient management issues. So we will put it on our monthly discussion as well. So we'll see how come this happened. Actually, it's really make me sad as well. I
Doctor,
believe that.
how about my stroke? Is there anything that you all can offer?
Sorry.
How about my stroke? Is there anything that you all can offer?
Yeah, actually, we will be going to closely monitor you. So maybe I will talk with my consultant to do some repeat CT scan of your or MRI scan of your brain and spine, and maybe we would like to do some blood tests to rule out all of the problem. But as you don't have, do you have fever?
Sorry?
Do you have any fever?
No, doctor. Why you keep asking me all these symptoms?
I'm so
I
sorry.
want to know. I want to know what is the next step. Why are you keep asking me all these symptoms?
First of all, it is your current condition is our top priority. So we would like to make sure that you are not suffering of any consequence of this actually tapping that has been done unnecessarily on you. I'm so sorry again and again.
So you haven't tell me what you all can offer for my stroke.
Yeah. So actually, Miss Aisha, will be actually our consultant has decided that you will be in we are not going to do any surgical option. So
Does that mean that there's nothing can be offered? I was just going to monitor here in the ward. There's nothing
no.
else that you're all going to do for me?
Yeah. No, actually, so sorry that we will actually, I will refer you we will refer you to a multidisciplinary team. There will be physiotherapist, occupational therapist, and speech and language therapist, as well as some nerve doctors as well. So, and then so as a whole, we will manage you. So we will be given some medications as well. So that all this together, I hope you will improve in near future. So, Miss Madam Aisha, are you taking excessive amount of alcohol? I'm so sorry to ask you.
No, I don't drink alcohol, doctor.
Okay, are you smoking?
Occasionally, my husband smoke, and he smoke inside the house.
I'm so sorry to hear that. I think your husband should not smoke in front of you because you have some uh, episode like a stroke, so it can aggravate. So if next time you can bring your husband with me, and I hope you can, if you tell him, he will actually accept your request, and you can bring him next time with me actually to discuss about this, so that we can also make sure that at home you are not exposed to any smoking at all, because Smoking is very bad. Even someone smoke nearby to you is equally bad. So I need your attention that please don't get exposed to smoke.
Okay, doctor.
So who is staying with you? Your husband or other kids? Anyone?
Yeah, yeah, I stay with my husband. My
Hmm.
kids are all they study outstation.
So what is your job actually? What occupation you are doing?
I'm a housewife.
Okay.
But
So
I do drive sometimes to go to buy groceries. Can I still drive, doctor?
I think for the time being you should not drive. You need to inform the the DVLA for this matter. But hopefully, if everything is settled, you will be able to drive. At this point, it's not safe, right?
How long, doctor? How long I cannot drive?
I'm not sure exactly how long. So we have the leaflets and brochure about this, and you can contact DVLA as well because actually every case is there are some case by case issues. So they will be able to advise you properly. And I will give you some leaflet brochures and contact number for that. Is it
Okay,
okay
doctor.
with you?
Okay, doctor.
Any other concern you have, Miss Aisha?
Yeah, I want to know how to prevent this thing from happening in future. You told me that your colleague supposed to poke the needle to my patient to my neighboring patient, but not me. Then how do you prevent this from happening next time? What's the things that hospital can do to improve?
Actually, what is your idea, Madam Aisha? Is there any Aisha idea you have that we can implement?
No, I want to know. I don't want to give idea. I want to know.
Okay, so maybe I would put this idea to put some more, the identification rings, identification something like paper bracelets, identification. So it might help to actually the maybe three-way identification, not only name and age, because sometimes the
2 minutes
name and age
left.
can be similar. So we can improve our identification system much better, and then marking. I think something need to be done. I seriously am so sorry, and I apologize from the whole medical team again to you.
Okay, doctor.
So, any other concern you have, Miss Aisha?
No, doctor.
Can we, can you tell me what I said about your stroke issues, and can you tell me in summary about what our discussion?
Yeah, doctor, I came in because of my high blood pressure, and this high blood pressure causes bleeding into the brain, and as I was quite okay. Your consultant, your boss say I don't need to do any surgery to remove the clot. I was monitored in the ward, and then suddenly one of your colleague poked the needle into the back of my spine, and then but this procedure is not supposed to be done on me, and you told me that it's okay, and then need to observe in the ward. May or may not have risk of causing worsening of of my condition, and I will complain. I will want to complain, and you will guide me for that.
Yeah, Miss Madam Aisha, actually, I'm again apologize from the whole medical team. It's actually, if you want to complain the information, I will pass you again. I make sure that your complaint is addressed and your medical management is not actually compromised. We'll make sure that you have get all the proper management from now on. Is it okay with you?
Yeah, okay, doctor.
So, any other concern you have?
No.
So, Miss Madam Aisha, so I'm so sorry again. Actually, it was nice to talk with you, and I hope that you will no complication what we discussed will not happen in your case, and you will be quite okay
Okay,
now.
time's up. You have 1 minute for reflection.
Okay.
Okay, time's up. Dr. Abu, can you talk to me a few issues that from this scenario, based on?
Yes, sir.
Hmm.
So there are actually. Sir, you want to ask me, or I should tell?
Yeah, yeah. Tell me what are the issues that you encounter in this
Actually,
scenario.
there are some very serious legal issues like medical error. So the complaint is actually a legal process. This is there. So, and there are some issues like consent as well. This is also the legal issue. So there are ethical issues involved. Is
No, no,
actually
no. I'm not talking about ethical or legal issue. What are
Mhm.
the issues that you encounter when you talk to Madam Aisha?
Actually, the Madam Aisha had some bleed resulting in the stroke, so which is supposed to be in a conservative management, but unfortunately, this lumbar puncture was done, so it was very difficult to address this concern because this is a clear-cut error from our side.
So, how do you find Madam Aisha concerned?
Yeah, Madam Aisha's concern was actually due to this procedure, what are the problems happened, and then another concern was his stroke, that what it could happen. So actually, I tried to address both of her concerns.
Hmm. So, have you explained to Madam Aisha what is mean by conservative management?
I said that actually medicine, some medicine, speech therapist, occupational therapist, and all those things will be given.
Sorry again, what you mentioned?
I did not mention actually the all conservative managers. So sorry, I did not mention, but I mentioned that there are some medicine. Some medicine will be given along with speech therapy, occupational therapy, physiotherapy, and speech and language assistance. All those things will be given.
Okay. So, tell me about legal issue in this scenario.
Legal issues are actually here. There is a medical error. There is
Hmm.
actually the complaint process. Then there is actually the consent.
Okay. How about ethical issue?
Ethical issue here is actually the autonomy. Madam Aisha have the autonomy to accept or reject all of the medical management options we provide here. As she is in full of her capacity. So the beneficence here that actually in this case there are some malfeasance happen in a sense that we did the lumbar puncture unnecessarily, but non-malfeasance in a sense that after the lumbar puncture we are monitoring her and we make sure that she don't have any headache or any infection or any bleeding inside. So we are monitoring her. This is actually non-malfeasance again. So the beneficence is that actually she had the right thalassemic bleed. We diagnosed it after CT scan, and actually we are managing her well in the hospital. So these are also beneficence. So also we are referring him to actually multidisciplinary team comprising this physiotherapy, occupational therapy, speech therapy, and comprising all these medications concerning the high blood pressure, controlling the risk factors in her case. So that's all are actually beneficence. And the justice is employed is actually we are going to treat her, even though she is going to, there is a chance that she will complain. But still in this condition, we will treat her equally like other patients. So this is actually the justice employs. And I had the duty of a very severe duty of truth telling. So when there is an error, so I have done with proper sympathy and empathy, I tried my best to admit our error and explain.
Hmm. Okay. Duty of truth telling. Do you know the another name for this?
Duty of candor.
Okay. All right. So, okay, Ken. I think you only got 1 minute left, but generally, I think you answer most of the question. Okay, we will start early. How do you feel? How do you find about this patient?
Oh, doctor, it's so many topics because you are right. I did not touch the medicine management, but the number one issue is actually, doctor, I have one clarification I want to get from you, doctor. So,
Hmm.
number one thing is I was in another course. So they said that currently in PACES, everything is medical error, no negligence. It's a team problem.
Yep, you're right.
Am I right? So I
Yes.
was stick to about medical error. I did not say we are negligent.
No,
I
no,
did not
no.
express the
We
pain as I
that
should not.
nowadays there's no negligence. Nowadays,
Everything is error.
every mistake that we make is considered medical error until it's proven by judge that this is a negligence. So
Excellent.
this is a medical error. But you did a very serious mistake in this
Mistake,
station.
okay.
Do you realize that?
jargon. One single jargon is single phase.
No, jargon is something very minor. You did
Okay.
one very fatal mistake, I would say.
Oof, where is
Not
that?
only one, actually, in fact, twice.
Oof, what is that?
You ask history.
Actually, doctor, I have some confusion actually. I seriously get confused about station 4 and station 2. Because here, this is actually, you ask me to tell the condition, and very good that I am exposed with you in this condition. Maybe otherwise I will do the same thing in the example. So you asked me to talk about the stroke, right? But isn't it, I need to know, it's a lumbar puncture. So patient might have the bleed, patient might have some herniation, patient might have some headache, patient might have some infection. So I need to rule out that, am I right? Or no
Correct,
need
but
to?
you cannot ask the patient all these symptoms because this is a station of communication.
So how can I address that then?
So you can do it two ways. It's either asking patient to tell it, or indirectly telling it, or you explain it in a way that you may experience this and that. Understand? So how to do it indirectly? So you will yes. So if you are going to do it, if I'm going to do it, I'm going to ask. I say there are few potential. Unfortunately, Madam Aisha, there are few potential complications that you may experience after we have done the procedure. First is the risk of infection. We will monitor you to make sure that you have no fever, and we may need to start your antibiotic for this reason. Second thing is there's always a risk of causing bleeding into the lining of the brain, and for this reason we also need to observe you, making sure that you have no any new signs of weakness, and if there is, we may need to repeat a brain scan for you. Is it okay? No, this scenario doesn't need you to ask patient got headache or not, patient got fever or not. You shouldn't do that, because the scenario outside for station 4, there's always one clause below which I didn't include. Please do not take history and examine the patient. There will definitely be this stamp in all station 4. Okay, so how to avoid taking history is by not asking HOPI at all. And how to know whether patient got any complication or not is to ask indirectly, how are you feeling at the moment?
Got it.
Yes, how are you feeling at the moment? Doctor, I feel fine and no issue. Then it means that there's no headache, there's no everything else already.
Wow.
You don't need to ask specific for that. You're not in the history taking station. So because by asking the direct question like this, examiner will be very serious, because this is a stamp that you should not ask history. But at the same time, there's something that you miss in your management. You didn't mention about what is mean by conservative management. It is as if nothing was done and the patient is just continue observed in the ward. And you didn't mention about the management until I asked you the third time. Actually, I asked you 3 times, Doctor, what are you going to
I'm so
do
sorry.
for the stroke? What is the thing you're going to do for stroke? Is there anything else to offer? I asked you 3 times only, you managed to mention about occupational therapy, physiotherapy, multidisciplinary team. You should mention that routinely. You say that stroke have occurred, damage has done, but we can start you on a few medication to control your blood pressure. And you should also mention that the blood pressure need to be controlled. You didn't mention anything about the blood pressure control, because we know that
Yeah, I did not.
in a bleeding in a hemorrhagic stroke, we should keep BP less than 140/90, right? Normal blood pressure. You should mention that you'll be observed in our intensive unit, and we need to make sure your blood pressure is controlled well to make sure that the bleed is not worsening. And this is for the right thalamic bleed. This is not even about the LP post complication yet. So you should mention that we also need to let the physiotherapist see you to make sure that you can do some exercise, which is good for your recovery and rehabilitation. You should mention about all those management, focusing on all those management instead of keep apologizing for the medical error. Yes, we need to repeat our apology, but you need to moving forward, we still need to provide the best care that we can. And generally, your complaint will also not affect our management. You should stress on this fact.
I did also, right? I tell them.
Yeah, you tell that, but the problem is that you didn't mention what are you going to do until I asked you until the very end. And
So,
and another question for you is that the social history, I realized that you didn't explore a bit more. So we know that in station 4 you cannot ask HOPI, you cannot ask past medical history, you cannot ask drug history, you cannot ask history of presenting complaint, but you can ask about social history. And this social history constitute a lot of things. So my question, if I have time as an examiner, I will ask you, have you explored why the patient have a uncontrolled hypertension?
So again, I will not be complained that I am taking the history. So are you taking the medications regularly? Can I ask it to become history, isn't it?
I would advise against asking this. A smarter way to do that is you can tell the patient that it's also very important for us to tell you to make sure that you're really taking your blood pressure medication, to make sure your blood pressure is on the control side. If the blood pressure is not controlled well, we need to add on some medication to bring down your blood pressure more. I will mention just like that. You understand or not?
So
yeah.
actually,
Instead of asking, are you compliant to the medication? It's like interrogating the patient at the same time you are kind of like asking the history. So it's not a good approach. The better approach is to, instead of being judgmental, patient take or not take the medication, you just tell that we will need to control the blood pressure well, and for this reason, you need to make sure that you take the medication regularly. And if it's not optimized, we will need to see you regularly to maybe add on a few medication to make sure your blood pressure is optimized. You can just mention like that.
So, but for social history part, doctor. So
Yes.
I got it about the medication, how to trick. So, but social history part, we are supposed to ask about smoking, alcohol, and driving. Can
Yes.
we ask about diet?
Yes, you asked, but you didn't ask about support.
Support, I asked. I said with whom you are staying.
Yeah, I mean, you're staying with just husband, but you did not ask whether anyone can take care of her. Who knows, the husband is actually working all the time.
That's right.
Yeah, the most important thing about social history, yes, smoking and alcohol is important mainly to modify the lifestyle, okay? But the more important thing is actually how the patient condition affects the patient activity, which means any family support, we are talking about support in the sense of social support and financial support. For this station, financial support is not important. It's a social support. So instead of you can ask a very good social issue in the sense that who else are with her, things like that. But you need to know whether anyone taking care of her. That's the single most important question. So you can ask like got children, things like that, but if let's say everyone is like working, then who else is going to taking care of her? And she may suffer from complication of stroke, which is immobilization and deconditioning if she's not moving much. So therefore she will need a lot of care at home. And therefore it's important. I mean, exam for station 4 is like template. We have to have a framework, but doesn't mean that we need to always go very rigid in the way that we follow our template. The more important thing, if you think from the patient aspect, is when you ask about social issue, you want to know whether patient can take care of herself or anyone can take care of her. And is there anything that we can prevent this from happening? For example, prevent this bleeding stroke from happening, in which you need to counsel the compliance to medication, and then you need to advise to reduce the CVS, all the CVS risks. Okay, and the next thing is actually how to improve it better. The patient asks you how to prevent this from happening, right? I mean, doing LP at the wrong patient at almost same name. You mentioned about three level identification. So for layman's term, it's a bit difficult to understand what it means by 3 level identification. So you should mention to the patient that ideally we will need to check the patient's full name with the IC as well as our registration number. You should mention like that instead of just like 3 level, because not everyone can understand 3 level. We are all medically trained, then we can understand. But if you expect patient will understand 3 level, they will not. They don't know what is each level. So that's why it's important. I think generally your counseling is quite okay. It's just that you cannot do mistake like asking history. It's good that you do it now because you know next time you should avoid doing it. Okay?
So doctor, can I get some more clarification? Actually, the social history part, as you said, that is smoking, alcohol, driving, and support. Other than this, nothing should be asked. And other thing, we just indirect thinking. We will just say that you should not do that, should not do that. If she talks from herself, it's okay. Or we will give you that, right?
Social history is not only about all this. Yes, you mentioned driving. Driving is important for stroke and also for those that listed under DVLA, blurring of vision, all those indicated scenario. Okay, but it's not only about things that you mentioned. Sometimes it's also more than that, depending on the scenario. So I cannot tell you exactly for this scenario, yes, only this is adequate, but not applicable for all scenario. Some scenario requires like no people taking care. You need to tell that refer to social welfare. Sometimes some patients have difficulty for work. You need to refer to occupational health service to see how can we offer help. And then some patient may have some other social issue. For example, let's say they have other family members that's unwell. Then you may need to arrange also social welfare to try to take care of that family members, seeing that the patient is also unwell. So sometimes it may not be so rigid in the sense that only this aspect. Sometimes we may need to know what is the scenario and go in the line of it. Okay.
So this scenario, like the stroke, so diet and exercise, can I ask, or I just advise that you should take the control?
You should advise because the
Don't
power is
tell,
quite good,
okay?
right? Yeah. You should advise. You should say that once if your condition getting better, you can move more. I would advise encourage you to do exercise, things like that. You can mention diet change, no problem. But the principle is don't ask the patient, do you exercise or not? Do you take
Yeah,
this or not?
got it.
If you
Got
do
it.
that, then it's going to irritate the examiner.
Yeah, very, very important clarification you gave me, doctor. So another thing, I thought that patient is under hospital management already. So actually, the most important part was here for me to actually.
So it's not
manage
medical
the-
error. That yes, this is a medical error, but this is an incident reporting, lah. Oh. This is
So
actually
I
an incident
to say the
reporting.
incident report, right? I
You
said
can
incident-
mention both. You can mention both, but generally you need to make an incident reporting.
So I say already, but there is something like previously we were taught that standard incident report and critical incident report. This is no more, right? All incident report.
Don't need to be so specific. Just mention incident reporting.
Okay, doctor, thanks a lot.
Yeah.
for your very
So
good
another thing is that you don't know the DVLA rules for stroke. How long to stop driving. So for DVLA for either TIA or stroke, the DVLA rules is actually 1 month for a class 1, which is the normal car, and then 1 year is for those all the heavy vehicle class 2. But you need to know I mean you kind of like need to know, but sometimes examiner may not ask you, some local examiner may not ask you, but you will never know if you get the international examiner. Is a UK examiner, they will ask you this question because this is a UK exam. And if you really stuck, you cannot remember. This is DVLA is something I only remember before I go in exam, like one night before. But generally, you need to know general principle lah. Stroke TIA is 1 month. Okay, there's something that is also 1 month. For example, like MI, we already underwent reperfusion. Some are 6 weeks without reperfusion therapy. And for example, seizure is something that is very common that we need to know as well.
Everybody
Okay,
can say.
whether it's a 1 year, okay, 6 months, 1 year, or 5 years, 10 years, okay, depending on the class 1 or class 2. If you cannot remember, instead of say not sure or different people different, it's not different people different, it's the same rules that apply for everyone. Instead of saying all this, you can say that I'm not entirely sure. You can say that, but I will make sure that you can get in touch with the DVLA and they will advise you further in terms of the duration. It's okay if you stay that. Instead of no, but don't mention that like what you say is a bit kasihan, because you mentioned that because everyone is different. It's not different. Actually, the rules is the same. So you should mention that maybe I'm not sure, not entirely sure, or I can refer you back to the DVLA to make sure that they will inform you the exact duration. Okay.
But doctor, someone has got the thrombolysis and without thrombolysis is not same, right?
Actually, DVLA did not specify much whether thrombolysis or not. DVLA, if you read through the UK guideline for the DVLA, they just mention whether it's a TIA or stroke, but the guideline is still 1 month. Generally,
TIA, I
even
think TIA 1 week, isn't it?
sorry, TIA is 1 week. You're right. TIA is 1 week.
But
and
I
then
cannot
for stroke-
exactly recall. Always I get confused. That's why I just.
Yeah, but
Okay.
but some also, if you look at the detailed guideline, high risk TIA is also considered 1 month. So generally, if you want to counsel 1 week to 1 month is okay. But you need to, if you're not sure, you can just tell to inform back DVLA. And this is just a scenario of medical error lah. So I think to discuss with everyone, because I think we seldom have any discussion on the medical error scenario. Sometimes patient can be very emotional. Today I try to be a better patient and not going to do a much of emotion. But generally you can see that you should have an approach. I can see your approach is there, but I feel that your approach is not good enough in the sense that you apologize immediately on behalf of what happened, but you didn't mention about lumbar puncture at all. I realized that you didn't mention anything about lumbar puncture. You should still mention just briefly about this procedure, okay? Because you cannot counsel anyone on the benefit and the complication that the patient is going to encounter without knowing what is this procedure to begin with. So you should actually explain. So my approach is actually ABAM lah. I will always use this self-created mnemonic so that I will follow the approach. So I'll admit that this is our mistake, this is a medical error. I want to apologize on behalf and explain about this procedure. It's actually the procedure to obtain a sample from the brain cavity, the brain fluid to call it, and send to the lab to know whether you are dealing with infection or any other condition. However, in this case, actually your condition is not indicated and actually it carry a small risk to your brain. So you should mention like that. And then in terms of incident reporting, you mentioned about you want to make a report, you want to inform a consultant, yes, and also the internal inquiry. So you should mention everything at one go lah, because I realize you spread it out. So you should mention that I have lodged for what happened. I have lodged an incident reporting, and then a medical expert team actually will carry out internal inquiry regarding how this and why this can happen, and this will help us to understand and prevent. The main idea is to prevent this from happening, which is you also mentioned, and then also I will also inform consultant in charge of your care. This is during hospitalization. I copy paste for other scenario. You can ignore it. The next thing is the best interest. You need to highlight the fact that we are providing the best interest. We are providing the best care at the best interest, at the patient best interest. So you may want to repeat the apology. Very sorry for what happened, but please assure that our management will be at your best interest. And then you have the right to make complaint, the autonomy, and can direct you to the patient advisory license service. Or in Malaysia, we don't have PACES. You can say that I will direct you to the complaint department. It's also okay if you cannot remember what is PACES. And then you may need to repeat again a few times to reassure the patient. And then the next thing you need to focus is the management. Actually, for this scenario, you need to really focus on the management, because you must mention that you'll be observed for a few days to make sure there's no worsening of condition. And then you need to also focus on the stroke management. You referral to the occupational therapist, physiotherapist, and then home modification if required. And then social part, yes, you need to counsel. I think generally you cover most of the thing, and that's it. And the legal issue, yes, ethical issue, incident reporting, and medical error. And for any scenario of medical error or incident reporting, the additional point that we should mention under ethical scenario is the duty of candor, in which you mention. But if I'm you, if the time is short, I will tend to mention it first, because I know that this is very important. I need to mention that instead of, yes, autonomy, maleficent, non-maleficent, justice is all important as well, but you really need to mention the duty of candor. Because let's say you only got 1 minute left, you start with autonomy and you give example and quite long, and then you somehow got few example for beneficent and non-beneficent, and then time's out. Then you didn't have time to mention about duty of candor, because this is a scenario that duty of candor is very important. Duty of candor means the truth telling, like you say, the need for us to be honest to the patient when things goes wrong, whether or not there is any apparent harm to the patient, regardless of any apparent harm to the patient. Like this scenario, I mean, from what patient tell you and from the scenario mentioned outside, seems like there's no apparent harm to the patient, but we still need to tell the patient truth telling. Okay?
So, doctor, if the patient got harm, this scenario no harm, right? If the patient got harm, I thought that this is duty of candor. So it's not like that. Any medical error, this is a duty of candor. Okay, I got it.
Yeah, correct.
So another thing is, if the patient got harm, is it medical negligence or no more negligence? Still, it's a medical error.
No.
As long as
don't ever mention negligence in exam. Just mention as medical error.
Yeah, that's what actually now very clear. This practice was very good eye opener, and thank you so much for your
Thank you.
time and
energy.
So
the NHS, that is something like medical error. If you can go through their guideline, even in their guideline, NHS also, they didn't mention about negligence at all. This term has been removed. They only talk about medical error and incident reporting. So negligence is something that we should just remove it out of our mind when we go for exam, because we are not lawyer. Only lawyer can say we are medically negligent. We are all having any medical error. Any harm to the patient also is considered medical error. But if let's say this patient got any harm, our focus should also try to do, let's say let's say this patient has what you call go for some procedure, and the patient didn't not being counseled for something, and the patient is unhappy, and the procedure didn't go through well and got complication from the procedure. This kind of scenario is no longer a scenario of explaining the complication from the procedure. Instead, this is considered a medical error if, let's say, the patient is not informed, patient is not being counseled before going for procedure and develop complication. So this kind of scenario, let's say got apparent harm to the patient, the management will really need to be focusing on reversing the harm. So we need to do damage control. We need to focusing on damage control. Mention that everything has been done with, for example, surgical team has been referred, this and that has been done, and then the next step is like this. So you need to mention about what was been done. For this scenario, there's nothing to be done, just observe. But for other scenario, we need to mention what are the things that already been done, or the initial step that already been done to avoid causing more damage to the patient. Okay, and another thing is that always a scenario of medical error, we always tend to confuse from my personal experience also. Sometimes we will confuse a scenario whether this is to counsel for medical error or to counsel for complication from procedure. Let's say patient have achalasia, went for balloon dilatation, and then causes esophageal perforation. Is this considered medical error? So let's say the patient is being counseled and already know this, then this is actually a complication from procedure. But let's say the patient is very unhappy, you ask, so how do you know whether patient is being counseled or not? Is to ask the patient how they feel about it and how they think about it. Okay, because we cannot ask history directly. You cannot straight away ask, so did the doctor tell you before that? Cannot ask the history just like that. So you must mention to the patient, you can ask the patient that what have you been told regarding this procedure, and how do you think about this for the things that had happened? So the patient will tell you, the doctor did counsel me and have encountered this. Then yes, you are not dealing with medical error anymore. You should not tell this is a medical error, but you should focusing on so-called damage control and so-called what are the next step moving forward. Okay, but not labeling as medical error and file for incident reporting, because we know that for procedure, complications are prone to happen. But generally, does it mean that the approach for medical error and incident reporting different from the complication from procedure in terms of counseling? Actually not. The approach is exactly the same. We still need to admit, still need to apologize and explain. However, we don't need to issue any incident reporting. And we still need to give the best interest, autonomy, and repeat, and also provide the subsequent management. So the only difference is that there's no incident reporting when you actually counsel in terms of complication from procedure. I hope everyone understands about this, because we always tend to a bit confusing when we go for exam. We don't know whether which direction we are going. Some scenario may not be very straightforward. Some scenario are those scenario like need you to make a foot. You really need to step a foot and put a firm decision. What are you going to do? Let's say a patient with SLE, lupus nephritis, and then based on the scenario outside, liver function is still deranged, renal profile is also deranged, and patient now is like 12 weeks pregnancy, and the scenario is just to discuss the patient regarding the next subsequent management. Did not tell you to discuss termination of pregnancy, did not tell you to discuss whether patient can continue pregnancy or not. This kind of scenario is for you to decide. So it's not easy sometimes. So the scenario may not be very straightforward. If this kind of scenario come out, you really need to be careful, because you need to prepare two sets of solution when you are outside. When you are not sure which direction you are going, you should prepare for both. Let's say you want to counsel for termination of pregnancy. Let's say for this case, that scenario. So you need to make sure you need to counsel that the patient birth result is not good, the SLE is not well controlled, it's not advisable. But sometimes you may not need to put your foot 100% like that. You can also involve your consultant. You can also discuss the patient, arrange an urgent next meeting with, for example, ONG team. You can also ask patient to consider about it. At the end of the day, this is a patient autonomy, and you may not want to commit that straight away ask patient to terminate the pregnancy. So the idea is to, the trick for communication skill is sometimes we may not need to commit 100%. but you need to have a certain direction. You cannot tell the patient, oh, you can continue pregnancy. No, you cannot do that. You can always say that the patient have a very high risk of continuing the pregnancy. We generally advise against continuing pregnancy. However, I also understand that it's very difficult for you to accept at this point of time. If possible, I would like to engage, like to make sure I will arrange another appointment to talk to my consultant and also to refer to our female doctor, so that we can get a conclusion and you can understand more about this. Are you okay? So this is how we counsel. We don't want to, put the foot, say you must terminate, and because sometimes when we do 100% commit to a certain decision, we will kind of like neglecting the patient welfare in terms of emotion. They will start to be very teary, they will start to be like, for example, very emotional, and we tend not to address that concern anymore because our role is to terminate the pregnancy. So it seems like very zalim lah, very less emotional and empathic. So that's why sometimes we have to see how the counseling goes. May not be straightforward. Okay. So that's all for this station 4. Anyone have any question?
Doctor, I have one more question. I'm so sorry for asking so many questions.
No worries, you can ask.
So actually, these are the common confusion I think we all have. So actually, let's say that achalasia cardia, we inform him well, and then we make perforation. So of course, we are not going to say that actually it is a medical error. It's not an incident report, but still, do we need to do this hospital mortality and morbidity meeting?
No. Don't need to mention about that unless the scenario tell you to mention.
So no need to tell anything. But indeed, in reality, hospital will actually analyze this, isn't it?
Correct. But how often
the departmental analysis will be done?
Yes.
Everybody will sit together.
But how often did the patient know about this M&M? Not really, right? So meaning to say, in the sense that when you counsel the patient during the exam setting, you don't need to mention things that are not necessary and sometimes may be controversial. M&M is something you want to mention, not to say you cannot. Just that some examiners may ask you further on that. So there's also some confusion, like let's say this is a medical error, and then you talked about patient about the discussion from the medical expert team to the internal inquiry, and then there's also some candidate that counsel that the patient will also be involved in the internal inquiry to know about what was the result of it, and then to actively engage in it to see how to go about it, which is also quite risky when you talk about that. And some discourage the patient about knowing the result of the internal inquiry, get involved during the investigation. So you can see that there's a lot of controversial thing that's the reason why I didn't mention any of that, because if possible, if the examiner don't ask, you don't need to explain. And whether or not you should involve patient as part of the investigation in the internal inquiry is questionable. Every center is different, every hospital is different, and every country also a bit different. So there's no general answer to that. So it's difficult to answer. So in short, don't waste the time, don't answer it. Don't even ask about it and explain about it. You just need to say that there's an internal inquiry that's going to be done. No need to mention about the M&M meeting and all those things. We can say that after the result is out, after you investigated in detail, we will tell you about what is the result. And the idea of this internal inquiry is not to find fault. It's actually to prevent that from happening to the next patient, or for this patient if he or she comes again in the hospital. The idea is for prevention, it's not to find fault. Okay?
Thank you, Doctor, for all those clarifications.
Yeah, thank you, Dr. Abu. Okay, so we will go to Dr. Abigail. Are you ready, Dr. Abigail?
Yes.
Yeah, sorry, I think it's a bit late.
I'm so sorry.
It's only 4 o'clock. Never mind, I promise we'll finish before 5. Okay, so you will have 2 scenarios. One is station 2, then continue with station 4. So you will have 4 minutes to prepare for. Actually, it's 5 minutes, but I will give you 4 minutes because 1 minute, and then most of the time we are walking around and traveling from one station to another. So it's better you get 4 minutes to prepare station 2. Okay, so you are ready, yeah?
Yeah.
Okay, we will start the timer now. Okay, time's up. Let's start. So this is patient Miss Wong.
Okay, hello, good afternoon, Miss Wong. I would like to confirm your identity. You are Miss Wong, 30 years old?
Yes.
Yeah, I'm your doctor here today in medical ward. My name is Dr. Abby. So before we start our conversation, I would I will inform that during this conversation, I will be jotting down some notes. Please be assured that all these will be private and confidential.
Okay, doctor.
Yeah, I come to know that you have this headache for the past 3 days. Would you tell me more about that?
Yeah, doctor, I've been having this headache ongoing for the past 3 days. So it's actually very disturbing for me. It occur at the both side of my head, and it's actually throbbing kind of nature. I don't know what is this.
May I know, is this the first time you're having this headache?
Yeah, first time.
Okay, as you said just now, you are having it on both sides. May I know, is it at the front or at the back?
At the side and also the front.
Okay, would you mind describe to me what's the character like?
Yeah, like I say, it's like throbbing kind of pain, and then it
Okay.
occurs about on and off like that, but it generally did not go away.
Do you mean that it comes in episode?
Not really come in episode. For the past 3 days has been persistently having pain, but occasionally it become worse.
Okay, how do you describe does the pain started gradually or suddenly?
Yeah, it started gradually. So initially I was like having pain over my left forehead as well as the left side of my head. Then now actually both sides also having pain.
Okay, does the pain go any other parts of your head?
No,
Any towards your neck?
no.
Okay, anything that you did that can actually make the pain become worsen?
Not sure. For example,
For example, like light
no,
or noisy environment?
no.
Okay, how about do you did anything to help with your headache?
Yeah, I take some Panadol, but the pain is still there.
Okay, may I know, how are you taking the Panadol? I mean, in one day, how many dose or how many tablet you are taking it?
So for the past 3 days, I only taken 3 times per day. Each is actually 2 tablet, 1 gram.
Okay, are you on any other painkiller other than Panadol?
No.
Okay, how about the timing? Is the headache come with any particular timing, like you had the headache when you first waking up early in the morning or later on at night?
No, it lasted, it occurred throughout the day and night.
Okay, from the score of 0 to 10, how would you score your pain? So 0 is no pain at all, and 10 is the most pain you had, and 5 is the moderate pain. So how we score it?
So if persistent like that is about 3 to 4. Occasionally I do feel it become like 7 to 8.
Okay, so do you have any abnormal sensation or abnormal smell that you experienced before you had the headache?
No.
Okay, may I know the headache? You mean that the headache come in persistently throughout the day, right? Okay, how's the progression of the headache? Is it becoming worse?
Yeah, I think it's becoming worse.
Do you have any red eye,
No.
tearing of the eye?
No.
Do you feel pain whenever you try to wash your face or whenever you brush your teeth?
No.
Okay, do you have any vision problem?
No.
Do you see doubles?
No.
Do you have any vomiting with the headache?
No.
Okay. Do you have any weakness over your arms and also your legs?
No.
Do you have any trauma, like you get into an accident?
No.
Do you have any abnormal sensation over your hand and also your leg?
No.
Do you have any fitting episode?
No.
Do you have any loss of consciousness?
No.
Do you have any fainting episode?
Fainting, no.
Do you have any problem with your swallowing?
No.
How about your speech?
Speech, as in the way I speak?
Yeah,
No.
yeah,
I think it's normal.
Okay. Do you have any have you any problem with walking?
No, I can still walk. It's
Are you
normal.
able to balance yourself whenever you walk?
Yeah.
Okay, how about are you able to control your bowel?
Yeah, can.
How about your bladder control?
Yeah, I can still can pass urine normally.
Okay, may I know how do you describe your mood recently? Do you have any stresses recently?
Yeah, I work as clerk, so I recently involved in a lot of paperwork, so it can be very stressful.
So For the past few weeks, do you have any problem with your sleep?
No, I can still sleep. Only for the recent 3 days cannot sleep well because of the pain.
Okay. So do you have any do you lost interest in your life recently?
No.
Okay. Do you have, sorry for asking this sensitive question. I would like to ask whether you have any attempt or any idea of ending your own life.
No, 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 no.
Okay, so I'm going to go through a series of questions which might not be relevant just to make sure that I didn't miss anything important. So do you have any shortness of breath?
No.
Do you have any difficulty lying flat and feeling breathless?
No.
Do you have wake up midnight feeling breathless?
No.
Do you have any leg swelling?
No.
Do you have any racing and pacing of heartbeat?
No.
Do you have any cough?
No.
Do you cough out blood?
No.
Do you have any noisy breathing?
No.
Do you have any runny nose?
No.
Do you have any change in appearance of your nose?
No.
Do you have any night sweat?
No.
Loss of weight?
No.
Loss of appetite?
No.
Do you have any fever?
Sorry, what?
Fever.
No. Oh, fever is it? Two
Oh,
weeks
yeah.
ago, 2 weeks ago, I got a bit of low grade fever lah.
May I know during that time, do you try to measure the temperature?
Yeah, I didn't try to measure temperature, but that time my left ear also got a bit of ringing sound, so that's why I go to see the GP. The GP give me some oral antibiotic to eat.
Do you know what's the name of the antibiotic?
I don't know, sorry.
Did you complete the antibiotic course?
Yeah, unfortunately I didn't because it's busy work schedule. I need to chase a lot of this paperwork. That's why I only taken 3 doses.
Okay, any problem with your hearing now?
My hearing now is getting better. I can hear well.
Okay, any discharge coming out from your ear?
Initially 2 weeks ago, yes, a bit of whitish discharge. Now no discharge.
Okay, so have you recovered fully from the fever previously?
Yeah, previously, I mean for the first 1 or 2 weeks ago, there is a bit of fever, I think. Then subsequently no more. Currently no fever.
Okay, do you have any teeth in?
Any what?
Tummy ache.
No.
Do you have any tummy swelling?
No.
Did anyone comment that you look pale compared to previously?
No.
Do you have any yellowish discoloration of your eye?
No.
Any changes in your stool?
No.
Any changes in your bowel habit?
No.
Any blood in your stool?
No.
Any problem with your urination?
Yeah, I've stayed my I can pass urine well, normal, no issue.
Any blood, any bubbles in your urine?
No.
Okay. Do you have any joint pain?
No.
Do you have any rash?
No.
Do you have any excessive loss of hair?
No.
Oral sores?
No.
Did your hand change color whenever you are being exposed to the cold weather?
No.
Do you have any skin thickening over your hand and also your face?
No.
Do you have any history of clot in your legs?
No.
Do you have any history of being miscarriage?
Yeah, doctor, I have one miscarriage before lah. It's at the first trimester, about 10 to 12 weeks like that. Cannot remember exactly.
Okay,
And therefore now I'm on
yeah.
this hormone pills lah.
Okay. May I know how long have you been on this hormone pill?
I had a miscarriage 2 years ago lah. So since then has been on hormone pills almost 2 years already.
Okay, is there any recent change in your hormone pill?
No.
Okay. Do you have any skin pigmentation over your body?
No.
Do you have any feeling giddy whenever you're standing up from a sitting position?
No.
Okay. Do you have any discharge from your breast?
No.
May I know when is your last childbirth?
I did not able to give birth to my child. I only got one miscarriage 2 years ago.
Oh, okay. Do you have any weather preferences?
No.
Neck swelling?
No.
Shakiness of your hand?
No.
Do you have purple lines over your tummy?
No.
Any increase in size of your hand and also your feet?
No.
Okay, may I know previously what medical history that you have?
I don't have any medical condition in the past lah. I'm very
Okay.
healthy. Yeah.
Do you have any surgery done before?
No.
Okay, may I know what do you work? Sorry, you work as a clerk, right?
Yeah.
Okay, may I know are you married?
Yes, yes. I with my husband.
Okay, any problem with your intimate relationship with your husband?
No.
Okay, may I know how about your family history?
Family history. I mean, no one is unwell. I suppose it's okay.
Do you take any alcohol?
No, no, no. I don't take.
Do you smoke?
Occasionally I do smoke, but generally I stop already.
May I know how many sticks and for how long you have been smoking?
Yeah, I only go for only for social reason, lah, not routinely.
Okay, may I know other than the hormone pill, are you on any other medication?
No,
How about over-counter medication?
no,
Any party drugs?
no,
Do you have any allergy to any food or medication?
no.
Okay, so Miss Wong, do you have any concern for me?
Yeah, so doctor, what is the cause of my headache?
Miss Wong, from my brief conversation with you, I think you are having a medical condition which is known as idiopathic intracranial hypertension. It is mainly increase in pressure over your brain, which is likely to be caused by the hormone pills you are taking for the past 2 years.
2 minutes left. But doctor, it's already for 2 years I'm taking. How can I suddenly explain have this headache for 3 days?
Okay, this condition can actually happen even though the medication has been started for quite some time. Yeah.
Okay, and will this
Or
headache occur back if I continue the medication?
likely will be continued. So actually, I will discuss with your gynecologist to see whether we can change to other forms of medication.
I see. Doctor, can this be stroke? I'm very worried. Suddenly I got headache for 3 days.
Since you have not have abnormal sensation as well as there is no weakness over your hand and also leg, it's very unlikely that you have stroke.
Okay. Is this condition curable?
This is a curable condition.
Okay. So can I get pregnant later?
After your condition is well controlled, I think the chance of you getting pregnant is quite high.
Okay. Okay, alright, doctor. I have no more concern. Still got 30 seconds?
Do you have any traveling history?
No.
That's all.
Okay, alright. So you may proceed with 1 minute reflection earlier. Okay, Dr. Abigail, can you tell me what is your working diagnosis and your differential diagnosis?
My working diagnosis for this patient would be idiopathic intracranial hypertension. Other diagnosis would be
What is your supporting evidence for this condition?
Okay, the supporting points would be there is no any neurological deficit in this patient, and there is no aura suggestive of migraine, even though the patient is having some stress in her work, but there is no point suggestive of any suicidal ideation.
But what are the points towards the IIH?
History of taking OCPs for past 2 years.
Okay, alright. Any other differential?
Another differential I would like to put is maybe had a headache because of the query otitis media patient is having like 1 week ago.
Okay, so what would be the explanation for that? What would be the diagnosis?
No idea.
So you are saying that this can be due to ENT related headache.
Yeah.
Okay. Is there any other differential diagnosis?
Not that I can think of. Tension headache?
Possible. Okay. Alright. How will you investigate this patient?
I would like to investigate this patient by taking blood tests such as ubical ESR therapy to rule out any infective causes. And I would like to carry out a lumbar puncture by measure the opening pressure. So in case of IIH, the pressure will be high. And to send the CSF for culture sensitivity, brain stem, and as well as for TB. Then I would like to do a CT brain for this patient. So to look for any intracranial mass.
Okay. Anything else?
Maybe a full ENT examination.
Otoscopy, for example.
Yeah.
Then any other workup in terms of the blood investigation?
Blood culture.
But you are not suspecting infection, right? Or you are
Yeah.
suspecting infection? You are suspecting infection?
No.
Okay.
No.
Alright. Okay. How about in terms of the management?
Management, if this condition is proven to be IIH, then I would like to start the patient on acetazolamide to decrease the CSF production. And after confirming there is no intracranial mass, then I would like to do an LP for the patient as a diagnostic procedure as well as a treatment. So later on, if the patient is not responsive, then might need shunt surgery or optic nerve fenestration.
Okay. So will you do a multiple LP for her?
This is not advisable.
Okay. So let's say this patient, other than IIH, can this be due to some infection as well? You have mentioned that. But let's say the infection in the ear didn't resolve properly. What can it leads to?
Meningitis?
Okay, time's up. Okay, so this is the next station. Okay, time's out, Dr. Abi. This is Madam Suhaila. Please start.
Okay, good afternoon, Ms. Madam Raila. I'm your doctor here today in heart ward. I would like to confirm your identity. You are Madam Suhaila, 50 years old.
Yeah.
So, Madam Suhaila, do you want anyone to be with us during our conversation today?
No.
Okay, throughout our conversation, I will be writing down some notes. Please be assured that all this will be private and confidential. So, Madam Suhaila, do you have any idea about our session today?
Yeah, so doctor, what I understand is that I actually fainted at home and then I was brought to the hospital. And then I woke up, but I was told by the doctor in emergency that my heart rate is very slow and it's dangerous. And therefore, they put some wiring at my thigh and I'm admitted to this ward for observation.
Okay, Madam Suhaila, may I know how are your condition for the past 1 day? Are you feeling better now?
Yeah, I'm in the hospital now. I feel good. I have no symptom at all.
Okay, Madam Suhaila, it's very good that you have some idea about your condition. So our purpose this session today is to discuss about your condition as well as the treatment for the condition. So yes, you are right. You are being admitted because you had a very low heartbeat, and life-saving devices has been placed temporarily to actually to help to correct your heart rhythm. And in view of your condition is actually a long-term condition, you actually need permanent devices, in which the name is a permanent pacemaker. Pardon me for the medical jargon. So are you with me, Madam Suhaila?
Yeah. So you mean that I need to put on some device in my body for my whole life, right?
Yeah, correct.
Yeah.
So
Can I know
about the
more about
device?
this?
Sorry?
Yeah. Can I know more about this?
Okay, so this device is actually to maintain your heart rhythm. You are having a very low heart rhythm, and it might be very dangerous for you. It can actually cause that if these devices is not being installed in your body. So before we are going for these procedures, we will have your blood checked to make sure that your blood result is actually within the normal range. And if in case you are on any blood thinners, you might need to tell the doctor that did the procedure so that he will advise on you whether when to stop on the blood thinners. Okay,
Okay.
and one day before the procedure, you also need to be fasted the midnight before the procedure.
Mm-hmm.
Yeah. And during the procedure, you will be given some medication through your blood channels to put you to sleep so that you will not feel any pain or any discomfort throughout the procedures.
Okay. So,
Yeah.
but how about this device thing? Where is it going to be placed, and then what things that going to put in my blood channel?
Okay, there is actually two parts of the devices. First part is what we call leads or electrode. So I will be drawing for you the devices. So the leads and the electrodes will be placed into the muscles of your heart via blood channels over your thigh.
Mm-hmm.
Okay, so before putting in the electrodes or the leads, we will actually put some numbing agent on your thigh to make sure that you did not feel any pain. And your blood channel will be make a small cut over your blood channels, and a wire with the electrode will be put inside your blood channels and guided with imaging machine into your muscle of your heart, and it will be placed there after the position is being confirmed.
Okay.
Yeah. So after that, there's a second part of the procedure in which a battery reservoir will be placed under your collarbone.
Oh, collarbone? That means it's under my skin or my muscle?
Sorry?
It will be under my skin or it's like deeper?
Below, under your skin.
Oh, under my skin. Okay. Then who is going to perform this procedure?
So this procedure will be carried out by the heart specialist. Yeah.
Oh, okay. And how about after the procedure? Do I need to do anything?
So after the procedure, you'll be monitored in our ward, and imaging of the heart will be done to make sure that the devices is being placed at the correct position.
Mm-hmm.
And our doctor will also see you in the ward as well as in the clinic during follow-up to actually to adjust the devices so that it will fit you completely.
Okay.
To adjust the setting, yeah.
Okay.
So it might have a few visits before the correct setting or the most suitable setting can be found.
Can I be discharged after the procedure?
This procedure is usually a daycare procedure in which that it means that after the procedure, if you do not suffer any complication from the procedure, you can actually be discharged on the same day or on the next day morning.
Oh, because now I'm in the ward now, so I don't know. After the procedure, I can discharge the following day.
We will monitor you to make sure that after procedure, if no complication happen, then you might be able to discharge.
I see.
Yeah.
Then after I discharge, is there anything that I need to be aware?
Yeah. After you have discharged, you need to come to our follow up in the heart clinic regularly. And throughout the follow-up, we will adjust the setting, and you need to remember to inform your GP or any doctor that you meet if you got sick in future that you have these devices in your body, because of some imaging might not be compatible with this device.
Oh, okay. What are the potential complications that may experience if I agree for this?
Okay, the complication of this procedure will have, for example, like infection, and also you can also suffer from bleeding. However, all these complication is quite minor. Happens only in a small population of the patients, and with our experienced doctor, this complication actually rarely happen.
Oh, okay. And is this the one-off procedure? Do I need to like repeat the procedure again later on?
This is a procedure, the device can actually last for 5 to 10 years, but we will also need to change the battery once the battery has finished. So the battery changing procedure is actually a procedure which is shorter than the procedure to insert the device. Yeah. So I'd like to advise, so if anything like the bleeding, you notice there is bleeding coming out from your dressing, or there's any discharges from the dressing, or there's any pain, you have experienced very severe pain over the site of the wound, or if there is any chest pain or fainting episode, please come to us immediately.
Okay. Yeah, then doctor, can I use my handphone? Because sometimes I heard from others saying that I shouldn't use my handphone.
Actually, the device that we are going to put in your body is safe to be used with the normal gadgets like cell phone.
Oh, okay. That means it's safe to use. I can put it close to my chest also, no problem.
Actually, the device is more than 15 cm, and the site has to be away from the site that we have put in the device. That means that if the device is being placed on the right side, please you avoid using phone on your right ear. So you can have it on your left ear, and the distance should be more than 15 centimeters.
Okay. Then how about cooking? Because I enjoy cooking. I want to cook when I go back to home. And then anything I need to be aware of, because I'm also using the induction type.
So in case you are using induction type of the device, you have to it is actually not safe. So you have to change to other form of cooking devices.
Oh my God, that means I need to renovate my house.
Sorry?
Is that so? I really need to change cannot use the induction cooker anymore?
If the distance is far away, I think it is safe.
Oh, okay. Then is there anything else I need to be aware?
And when you are going through some security checkpoint, please bring along the card. Before you discharge, we actually give you the card saying that you have this device with you in your body and what is the type of the device. So when you are going through the security checkpoint, like for example, you go to the airport in the immigration, so you can actually show the security there that you are having this device with you. It will cause some noise or some sound from the security checkpoint.
I see. Okay.
Is there anything else that you would like to ask?
Yeah. Can I drive?
After the procedure, you can drive after 1 week of the device being installed.
Oh, I can drive. Okay. Then how should I agree for this procedure? Do I need to wait for you all to arrange
So
a date for
if
me?
you, yeah, this is the pamphlet and also the booklet about the procedure. So once you can have time reading through the booklet and pamphlet. So once you think that you are ready and you agree for this procedure, you can actually sign on the form. So
Okay.
may I know, Madam Suhaila, how is your family? I mean, is there anyone with you?
2 minutes left. Yeah, I'm staying with my husband at home.
So please be reminded that when you have done this procedure on the day of discharge, please bring someone with you because you cannot drive or you cannot take the public transport yourself. You need to have someone to be with you.
Okay, doctor.
Yeah. Is there anything else, Madam Suhaila?
Yeah, I want to know, doctor. Let's say I want to have intimate relationship with my husband. How long I can resume back?
For this question, I would like to confirm back with my consultant and I will arrange the next appointment with you. Is that okay?
Oh, okay, doctor.
Okay, Madam Suhaila, do you smoke?
No, I don't.
Okay, do you drink alcohol?
No.
Okay, any other question for me, Madam Suhaila?
No more. You got 1 minute, so if you have time, you must try to
Okay,
summarize.
summarize.
Don't let it stop and hang like that. It's very awkward. Okay.
Okay,
How do
Madam
you?
Suhaila, so do you mind summarize for me what you have, I mean, you have been told by this conversation?
So you ask patients to summarize is a bit lengthy. So you instead of asking patients to summarize, you can summarize easier lah. Because you only
Okay,
like
Madam. Okay.
few seconds.
Okay, Madam Suhaila, so you have this very low heartbeat, so it's very dangerous, life-threatening condition. So you will need a device to be placed on your heart. So the device is named, the name of the device is permanent pacemaker. So it's actually designed to correct your abnormal heart rhythm.
Oh, and you should also mention that there's certain lifestyle that we need to be aware and need to be changed, and it's also important. How about precaution? Okay, time's up lah, but just to discuss lah, and the precaution as well lah. The precaution after the procedure.
Okay.
If develop any breathlessness, any chest pain, or any discharge or any redness over the surgical over the site of the device, you have to come to hospital immediately. And then leaflet,
Okay.
brochure, everything. You mentioned that earlier, but you can mention that and also hospital contact lor. Try to make it a
Okay.
short summary. Huh?
Okay.
Okay, I think that's all. So we will discuss the station 2. How do you feel about station 2?
I think I didn't get a correct diagnosis.
So if you got if you got chance, what would be your diagnosis?
Some thrombosis.
Cerebral venous
Venous.
thrombosis. Yeah, so CVT can be infective or non-infective lah. So for infective cerebral venous thrombosis, particularly like ENT related, sometimes may not have fever because they are partially treated. So this is actually a case of infective cerebral venous thrombosis due to partially treated ear infection. I don't want to commit it's otitis media or what because we don't know, right? So we just say secondary partially treated ear infection lah. So yeah, but yes, IIH can be one of the differential diagnosis, but to have a sudden headache for 3 days, we still need to generally follow the approach for acute headache lah. IIH usually will not cause sudden headache. Usually it's a chronic headache. And I think in terms of your intimate relationship question, you asked about any problem during the intimate relationship. So it's also important for headache scenario to ask about any pain during intimate relationship. Because one of the scenario came out 2 years ago in UK was postcoital headache. The diagnosis was postcoital headache. And if we didn't ask particular question, they will not reveal this positive history lah. But otherwise, your history is very good. Your systemic review is also very good, but a bit lengthy. I think not an issue lah. If you can ask so many questions is in such a limited time is good enough. You can get most of the diagnosis. Just that I'm a bit disappointed because I thought you got the diagnosis. And suddenly the diagnosis become IIH. I was like, but this is acute headache, right? First episode. IIH usually will have a long-standing headache and before they come to hospital lah. Okay? So another red herring is actually the miscarriage lah, to actually prompt the discussion of APLS. But you didn't mention any of that because I think you think it's less likely, right?
Yeah.
Yeah, because there's no clot in the legs of the lung before, and then there's also no positive family history. Yeah, so I think it's okay. And generally, yes, meningoencephalitis also sometimes we need to exclude because for this patient he have some ear infection. Sometimes even the sinuses can actually ascend up to the bone and then it enters the meningeal membrane. So meningoencephalitis is something definitely I feel need to mention. Just that she does not have photophobia, does not have neck stiffness or any neurological symptom based on the history. Okay, and bear in mind that IIH can be preceded by OCP use, but non-infectious cerebral venous thrombosis can also preceded by OCP use. And the CVT, the risk factor, not CVT, sorry, the IIH risk factor is also obesity. So you should also ask any recent change in the weight. At the same time, how is your weight? Is your weight have any issue like on the higher side? So because obesity is also one of the risk factor for IIH lah. But if you ask me, I would say no. I'm actually quite thin. So this again is a point against the IIH. Okay, and yes, it can be the exact diagnosis is actually CVT lah. And then the diagnosis, because of suspecting CVT, you should actually also screen for other thrombotic condition lah. So autoimmune, although you ask the whole autoimmune screening question negative, but sometimes you still need to screen too lah. And MRI is definitely indicated. Let's say this is a scenario of IIH. What are the findings of MRI you're looking for? Dr. Abi, do you know? Hello, Dr. Abi? Can everyone hear me? Under the investigation part, right? So my next question is actually what are let's say this is IIH, what are the possible signs, possible sign that you will look for in MRI of the brain for IIH?
No idea.
No idea. So usually you will see some dilatation at the lateral ventricle as well as the globe itself. The globe will have, there's a specific finding for this, but no need to know. But just need to make sure that there is increase in the pressure generally. And that is actually sipping of the CSF. It's what we call a CSF steepage. The keyword is actually CSF steepage at the globe, retrobulbar region. And also the dilatation of all the lateral ventricles and the sinuses. And yes, education counseling. Let's say this is a CVT, then you need to start patient anticoagulation. And the role is actually, you can start with low molecular weight heparin first, followed by warfarin. And there's no role of giving DOAC lah. So don't mention DOAC because DOAC study for CVT is not strong yet at the moment. And then we should also stop OCP. And actually you should counsel patient to stop the OCP lah. You say maybe that can continue, but actually if you don't want to stay referral to ONG, you can say that actually can consider changing to the other types of hormonal pill lah. So this will actually helps without referring to the ONG. And the next thing is actually to reverse the CVT, which is infective in nature. That's why you need to start antibiotic. Okay, and then if you need pregnancy later, need to be planned, and then have to consider changing to low molecular weight heparin during the pregnancy because the VKA is contraindicated. Okay, any issue?
No.
Okay, right. So yeah, IIH is something you can definitely put in your differential diagnosis, but IIH will not explain why the patient give you a recent history of ear infection. Must be some clue because with the IIH you didn't able to tally the clue, right? So that's why you feel like maybe you didn't get the diagnosis. Based on that, you already feel that, right?
Yeah.
So, but otherwise your history is very good. The flow is very smooth. You ask very quick question, and you didn't delay much. I think it's a good one, huh? So next one is, before I go into the station 4, just want to talk about acute headache lah. I think you cover almost all, but I think you didn't manage to ask about bleeding part lah. Whether this can be ICH. You asked about trauma. And you also asked about illicit drug use. You asked about family history of any family history of note lah. For this region, for this scenario, you may want to ask a bit detail in the sense that any family history of kidney problem or any family history of bleeding. So this is actually to rule out any this hereditary hemorrhagic telangiectasia lah, which can occur in a patient with the SAH. But otherwise, I think you are quite okay. You know what to ask, especially acute headache is important to screen for pituitary symptom, because we know that any pituitary macro or micro adenoma can actually suddenly develop apoplexy and therefore presented with acute headache. And usually it's hyperacute headache, which is less than 1 day. So we should also divide the headache to be more than 1 day or less than 1 day. If it's so severe, it's usually like thundercrack headache, SAH, or even ICH because of the bleed, or it's because of the pituitary apoplexy. So these three are the one that tends to present very early because it's very severe. The second possibility is the acute headache, like what the patient has. It's important to ask the infective symptom early. And for acute headache, you should also ask about ENT symptom. Other than the ear, you should ask about the nose. Any nose block, any sneezing, or any recent painful throat, or any coughing, excessive cough, and then any discharge from the ear. So all those are quite important. So next thing is the CVT. The non-infective one, you should try to screen for like how we screen for PE for the prothrombotic condition. And vasculitis is something only we consider, especially in the older age group, like more than 50 years old. And you ask a full rheumatological screening, which is good. You also ask about drug history and the OTC. And yes, there's also possibility of can this be some form of chronic headache and have an acute exacerbation, like migraine, cluster, or tension headache. That's why I think you put the tension headache as one of your differential diagnosis is fair. And the next thing is if let's say patient has chronic hypertension, uncontrolled, not compliant to medication, you may want to think of PRES as well, posterior reversible encephalopathy syndrome, because they can present as acute headache. And generally, they may also have some predisposed condition. They may also be on some form of drugs like, for example, OCP, also smoker, and also maybe unwell. Okay, so generally this is for acute headache. So for station 4, your complete heart block, I realized that you didn't discuss about complete heart block at all. So you mentioned that the patient heart rate is slow, therefore need to put on pacemaker. That's the only thing you mentioned. But you should also mention just in a very simple and maybe just 1 or 2 sentence that why she really needs this pacemaker. Because you must mention that because this condition is when the chambers or the rooms in the heart is not communicating with each other and not contracting at the same time, and therefore leads to inadequate blood supply, and there is also a risk that the heart will suddenly stop. You must mention that there is also a risk that the heart will stop. Only by mentioning the complication, only then it's easy to kind of like convince the patient for this procedure. And then you have mentioned the indication to regulate the heart rate. And then life-saving, you should also stress on, because this condition can leads to death and the heart to stop. Therefore, this is actually a life-saving permanent option. Best procedure to relieve the symptom. And her life can return back to normal. Remember, in our comm skill, we always need to focusing on patient symptom, and how the disease affect the patient life as well as the symptom. That's why it's also important when you highlight this fact. Yes, pre-procedure you mentioned it very well, and post-procedure you also mentioned, during the procedure you mentioned about the pulse generator. If you don't want to mention that, you can just mention a small device like with a battery, with the size of matchbox, just like the matchbox, very small device put under the collarbone, and then the connecting wires will be placed for the blood channel, and then they will connect to actually stimulate the electrical circuit. Then sedation, actually for pacemaker insertion, not every time we need to really sedate, like give a GA. It can be done in LA or even a light sedation, and you need to mention about the aseptic technique should be a very clean procedure done under X-ray guidance. Don't need to mention like done under the imaging or I can't remember what words you use, but I remember you can make it simple like this under a series of x-rays lah, to make sure that it's in position, and then the area will be stitched. Post procedure to be monitored generally, but you forgot to mention two things I feel which is important. You should mention that actually for Malaysia we don't have medical alert lah, bracelet, but you should mention that the pacemaker card and as well as an alert card will be given so that to warn any doctors in contact later. You did mention that later on, but you should mention that so that the patient, the pacemaker registration card is also important. Sometimes need to know what type of pacemaker when patients suddenly present with collapse or something next time. So that's why you need to mention routinely that we give you the card which have details on this device as well as to alert the doctor next time when you come to hospital, and should have a bed rest for 3 to 7 days and can return to normal activity by 1 week. And you should also mention about this, in which you didn't mention, should avoid carry heavy object. This is probably one of the first thing we mention to the patient after the pacemaker insertion. I remember I always counsel the patient about this first before talking about driving and other thing, because they tend to do some daily activity job which require a lot of lifting the shoulder or carry heavy object. So all this cannot be done, and also heavy activity or contact sport should avoid at least 1 month. You can say 4 to 6 weeks or like at least 1 month. So yes, group 1, only 1 week you cannot drive, provided you are asymptomatic and there's no recent chest pain to suggest heart attack, and then can be monitored regularly in a clinic. So the next thing is actually you talk about complication, but remember in this scenario, I mean, just to make it perfect, I think your counseling for this scenario can get full marks. Just that to make it more perfect is that, remember for every procedure like renal biopsy, you need to counsel about failure of biopsy that may needs to repeat the procedure again. Same goes to liver biopsy, and same goes to this pacemaker insertion. There is always a risk that the pacemaker can dislodge the leads and may need to shift and readjust, and therefore the procedure may need to be repeated again later. So this is only the extra thing, but I think if you don't mention, it is fine. And the precaution you need to mention, need to attend the hospital if there were any symptom. And then this one is for another scenario, just ignore it. But generally avoid driving for only 1 week for this pacemaker insertion. And then yes, lifestyle modification, actually there's a lot of things to mention, but generally all the electric device should be kept 15 centimeter away. Initially you mentioned not an issue to use, but actually cannot. You still have to keep about 15 centimeter away. And as same as the headset and the ear set should be opposite ear, and then also at least 15 centimeter away. And the induction hob actually patient doesn't need to renovate the kitchen, cannot use the induction hub. Actually can use the stove and hub, but need to keep at least 60 centimeter away. Okay, this is actually based on NHS guideline. MRI generally is compatible, but need to check for the compatibility with the heart doctor. Airport security staff informed, yes, you mentioned that. If patient work in the high cable like a radio transmitter thing, then need to change because can actually interfere the electrical activities. And then should also avoid wearing any magnetic bracelet or magnet near the chest because we know that even the iPhone can really stop the pacemaker. So it's actually because iPhone inside also got magnet, so we should avoid any magnetic stuff near the chest. And in terms of intimate relationship, not contraindicated, but should avoid any position that press the pressure on the arm or the chest for the first 1 month. Same goes to the initial part, right? Avoid heavy lifting of the object for the first 1 month. And if the patient is concerned, you can say that actually the risk to develop heart attack is actually very low for this case. For this condition, and the battery generally lasts 5 to 10 years. You can say 6 to 10 years, and changing can be done on the same day. Generally, I think you cover most of the thing, very well. You really score very well, almost full marks. Okay, good job. Any question? Anyone have any question?
I want to ask a question. Yeah, for scenarios that they didn't ask us to go any direction, right? Like the one that we discussed just now about the SLE. So will we be penalized if we didn't decide like to take on which direction?
Good question. So actually there is no right or wrong, and it depends on the examiner. So sometimes actually we don't have to commit, like must convince until patient say yes, or must convince until patient say no. So the idea is actually to give time for patient to think about it, and then if the patient is undecided, can arrange another session, and then we'll talk about this issue again with our superior, which is our consultant, or it may involve multidisciplinary team. Sometimes may not be a decision that we can make alone. For example, let's say you just imagine ourselves as just general physician. We cannot make this decision by ourselves also. We need nephrologists, we need maybe cardiologists, we also need ONG for us to decide whether patient is safe to go for pregnancy. So in that condition, therefore, that's all. That's why it's not fair for us to commit immediately during the first session. I feel they won't brain us if we don't commit. But the idea is that we should advise against continuing the pregnancy. But we are not forcefully asking the patient to go for termination. So that is the idea of it. The idea is not to say, oh, you can go for can continue and monitor. If you do like that direction, definitely being penalized. But if you do like a scenario in which we counsel against, let patient to think, we'll consider, because patient have autonomy, we let the patient decide, but at the same time we arrange another session. I think that is a better ground. You have more flexibility. When the examiner asks you, then you don't feel committed to really advise against pregnancy, like that, and then patient refuse, then you forcefully advise, then it may seem that we are not managing the patient concern well. Okay.
Okay. Then for one of the mock tests that I went, I actually did for session 4, I got a case of CD toxin in a 80 plus years old lady, and the underlying I think got COPD as well. But previously ADL independent, and then the scenario is to explain to the son about the mom's condition. So actually during the session I tell the son that actually this CD is a reversible condition and it can be curable. And then during the session with examiner, they actually asked me, do you think this patient can survive from the CD toxin infection? So I think, I don't know whether they want me to discuss about DNR or what. They didn't mention anything in the stand, so I'm a bit confused.
Yeah, so this is definitely a scenario that I also face the same question and also same confusion when I prepare for the exam. So this kind of scenario is difficult because you don't have definite order from the question itself. So the idea is, first thing for this scenario, did they give you exam feedback?
I didn't request for
No,
it.
usually for mock they will give you the whole envelope, and inside will be their marking score, right? Then they will write something there one. They didn't give you, is it? No lah.
No.
Only telling you pass or fail like that with the score sheet. Okay. So how did you do for that station?
You mean the marks?
I mean for the mock for that particular station. Do you able to get?
I didn't know the marks.
Oh, you didn't know the marks one.
I know the marks. I only know the marks, but I don't know about their comment.
Yeah. How about the marks for that station when you do?
I think it's 12.
12 out of 14, right? No. 12 out of 16. Yeah, sorry. Long time didn't see the exam mark sheet. Yeah, 12 out of 16 lah. Okay, can. So before I share, I just want to know the scenario. Did they mention about the COPD part? Did they mention anything about the control of the COPD? Is it advanced COPD, or is it like COPD, good kind of COPD?
They did mention the patient is on inhaler but they didn't mention about the history of admission or that.
So this is again something that we need to assess. I remember I did a very fatal mistake during my mock in one of the, I think Terengganu, one of the station. Something like this, but it's a bit different. The patient has COPD, didn't mention what was the status, and then got also elderly, came in chest infection, and then the scenario is to counsel the and now the patient is developing worsening respiratory distress, require ICU admission. So your task is to counsel the family members on the subsequent management and address the concern. That was a STEM. So I failed this station badly. I think one of the examiner was a very old examiner. Give me 0 mark out of 16. And surprisingly, I still able to pass the exam for the mock. But very, very very shocking for me, because I got 0 for that station. 0 is like a straight penalty, You can really fail the exam if you don't do well in the history station. Let's say you screw out the comm skill for the current format. If you screw out the comm skill, your failing chance is very high if you don't do well in your BCC, any one of the BCC or your history taking. If your history taking is not perfect and your BCC didn't do well in one of the station, then you will fail because of the component. You will not pass the component. So that's why the comm skill is very important, the comm skill station. So the feedback I got from the examiner was I should not counsel DNAR for this patient. I should not counsel about resuscitation. I mean, I should not give the patient up because the patient, apparently the examiner are expecting me to ask about the COPD part, in which how to ask, because we cannot ask history, right? So we have to ask from the social history, any activity limitation, how is his job. The scenario, actually he works as a fisherman, he still can go for fishing every day, and then he still no functional limitation one. So for that scenario, patient came in respiratory distress, pneumonia, and then we should still go all out because pre-morbid he is good. So that's why I was very deeply penalized for actually counsel for DNAR. I actually counsel for DNAR, not for CPR, not for intubation, everything, maximum NIV, blah blah blah, then I got 0 mark. So this shows that how dangerous the comm skill can be, because you really need to know what are the idea, what are the STEM that the examiner actually expected to us to counsel. They must have some direction, right? So for your scenario, they must have some direction that the examiner thinks this patient not suitable for active resus and therefore need to counsel for DNAR. So you can see that my scenario and your scenario is like totally the opposite, right? Another end spectrum of it.
Yeah.
So how to decide is actually by asking, for this kind of scenario, you need to explore the pre-morbid. But you cannot ask HOPI, but you can ask it during your social history. But you can ask about whether how is the patient generally before he was admitted to the hospital. Are you staying with who are the primary caretaker, and are you staying with the patient, and then how is his I understand that he have lung condition, how is his control at home, can he still walk, can he still do daily activities. After if you establish that he's already bed bound, caretaker, and then already got clinical frailty scale of 7 to 8 like that, so you know that definitely the prognosis, the outcome is not going to be good, and therefore your counselling, for me I would not commit to straight away issue DNAR lah. I think it's a bit unfair to issue DNAR at this point of time. But I will just ask about 2 main sentences. First sentence I will ask is actually, have he ever expressed any wishes if he become unwell one day? If the answer is no, then you ask, have he appointed any family members to make decision on behalf of him if he is unable to do so in a very ill setting? Then I will just give them an idea that I'm afraid to tell that actually for his condition we are going to give the medication, we are going to do, you mentioned everything that you're going to do contact precaution, isolation, antibiotics, oral antibiotics like Vanco and fidaxomicin, things like that, and then you explain everything. However, there's always a risk that his condition may not able to recover well from this infection because of his general condition is not good to begin with when he was admitted to hospital, and therefore we should really consider talking about his resuscitation status if it's deteriorate later. Are you okay with that? I will just ask about that first. Let's say, because if the STEM really expecting us to counsel DNAR or counsel on active direction, right? The surrogate will prompt us one, and the surrogate, if he prompt out this question, the surrogate will definitely ask one. So yeah, doctor, I want to know. So how to go about that? So if they really ask you to commit active or not active, then you have to see the scenario. So if the scenario, like for example, is bedbound already, nursing home resident, so it's very poor, be morbid, then definitely you need to counsel DNAR lah. But for my scenario, fishermen go to fishing every day, very well controlled, blah blah blah. Then I counsel DNAR, that's why I gonna fail lah. So it happens like that. So comm skill sometimes is not very straightforward, especially when the STEM outside did not tell you what you need to do, and for you to make the decision. Any other question? Abigail, I think okay, right? You understand, right, what I'm trying to say? Sorry, I think I got disconnected again. Yeah, Abigail, where was I just now?
You are telling about your scenarios that
Then
penalize
after that,
the examiner
then did I?
penalize you. Then
That's all.
I think you still have to explore more about the
Yeah.
social lah.
So actually, I think my recording will mention all the things I mentioned. I don't know why it's suddenly gonna sign out for unknown reason. But the idea is that we need to explore the patient pre-morbid. If a patient is a nursing home resident, very frail to begin with, multiple comorbids, and actually the support may or may not be good, this kind of patient we need to talk about resuscitation and counsel towards DNAR lah. But let's say the patient is very well off to begin with, very good pre-morbid, then we should go active lah. Oh? So that's the principle. We shouldn't kind of like and DNAR all the elderly patient lah. That's the principle. Some examiner they don't like that. But I think your scenario must have some hidden thing that you need to explore, which may suggest the patient is not good in general. It's quite frail. So probably you can explore that during the social history, but you ask a bit more. Oh? And any other question before we end the this? I think no message, right? So I don't know why today the line is a bit not stable. Yeah. Okay. If no question, then we'll end our session today. We'll see everyone back at 8 o'clock. I think tonight is a bit fast because you only got four BCC. So I expect we will ending maybe in less than 2 hours. So we will start on time at 8 o'clock. Okay? Those who can join, you can join. And there's also one seat left. I will try to reserve for anyone that's going for Diet 2 in 5 or 6 days time. If no one that is going that wants the seat, then I will release it to anyone that is interested. Okay? Alright, see you all later.